Hi, everybody. We're going to get started. I'll introduce myself, and before my co-moderator takes over, I'm going to ask all the speakers to actually stay to your 10-minute time limit. We have 16 speakers in this session, 16, and so if everybody goes even 5 minutes over, we're not going to have any time for discussion. We'll be here till long after the sun is down. So my name is Craig Cooper-Smith. I come from Emory University in the United States.
And I'm Michael Kazar. Happy to have you all here and happy to introduce, without further delay, our first speaker, Maya Heitz, I hope I pronounced it correctly, from Brussels, talking about antiviral agents for all.
Good afternoon, everyone. I'm just going to make a correction. It's Hitesh, but a lot of people make the error, so no problem. So today, thank you very much. I want to thank all the organizers for inviting me to talk on this subject, and I think we can go ahead and start. So those are my disclosures, and if I'm talking about antiviral treatment, it's important that we talk about viral load dynamics as well. I think that many of you are very familiar with this schematic diagram of the SARS-CoV-2 infection, where we have the individual that gets infected, the viral load increases over time to reach a peak, and then it decreases. Most patients are going to present mild to moderate illness, but there are going to be a subgroup of patients that are going to evolve to severe illness and critical illness. Amongst these patients, many of them present cytokine storm and present excessive inflammation. And viral loads in these patients are variable. Since we're talking about viral dynamics, it's also maybe interesting to have a look at how we can model viral infections. So actually, if we go back in time, we can actually find publications on models made of viral respiratory infections. And what's interesting is to see that, yes, at the beginning of an infection, we have an exponential growth of infected cells. Then we have a period of elimination of these infected cells. And as you can see, we have a curve. I just made that go, sorry. So we have a curve, actually, and this curve can actually be represented by an equation. And the equation lets us figure out that, or calculate R0, which is the average number of cells infected by a single infected cell at the beginning of the infection. Now, using this information, we can actually go ahead and try to calculate when would be the best time to be giving antiviral treatments. When is it best effective? And as you can see, if we give an effective antiviral treatment at the very beginning of a viral infection, respiratory viral infection, we're going to really be able to clear the virus very quickly. On the other hand, if we give the treatment already after we've reached the peak viral load, we're actually going to have little impact on viral clearance. We can also use modeling to go a little bit farther, and because we were lucky at the beginning of the pandemic to have a publication where there was some 13 patients in South Korea that presented mild Covid19, and that they underwent very, very frequent nasopharyngeal swab sampling. We had there was a publication with very detailed information on viral load dynamics. Because of this, scientists were able to calculate the pharmacodynamic target for SARS-CoV-2. In other words, what would be the efficacy constant for SARS-CoV-2, or how much viral activity needs to be blocked to really reduce viral load? And so what they found was that the efficacy constant should really be 90%. So it's a pretty strong antiviral treatment that we need. Furthermore, the scientists also looked for different risk factors. Risk factors for showing slow decline in viral load, and patients above 65 years old were identified. And then factors for mortality, and here viral load or high viral load was identified. And then if you put the two models together, so viral dynamics and survival, what they found was that if we actually had an antiviral treatment with an efficacy constant of greater than 90%, duration of illness could actually be brought down to about 19 days to 15.5 days, and this could have an effect on mortality by decreasing it from 17% to 13%. And then if we even had a more efficacious antiviral treatment with an efficacy constant of 99%, we could actually decrease mortality from 17% to 10%. Well, this is all very interesting, but it does allow us to conclude certain things, even if this is only based on modeling, that blocking 90% of viral activity is needed to strongly reduce viral load. Furthermore, accelerating viral clearance could reduce mortality in patients with high risk factors for poor outcome. Nevertheless, we've come a long way over time, and a number of antiviral agents have been tested for COVID-19, and few have been found to be efficacious. And it's taken really longer than a marathon to finally identify, end of last December in 2020, that actually monoclonal antibodies might be of interest. But before really arriving to very positive results, several studies had to be halted in hospitalized COVID-19 patients for futility. There were 3 monoclonal antibodies being tested, and all patients were included in these studies. They weren't looking at seronegative or seropositive patients or patients with high viral loads. And it took a little bit longer to be able to show that actually mAbs have been proven to have effective antiviral treatment in mild to moderate non-hospitalized patients. Just more recently, the Recovery trial was also able to show, but it is non-published data still today, that seronegative, severe or critical COVID-19 patients treated with casirivimab and imdevimab also showed positive clinical outcome. If we really ask ourselves, however, how are critically ill patients doing, for example, in the Recovery trial, unfortunately, only 70 seronegative patients that were invasively mechanically ventilated were included in the trial. And just for information, there is still currently another monoclonal antibody being tested in hospitalized patients with severe forms of COVID, but not in critically ill patients. And it's the AZD7442, so a cocktail from AstraZeneca that is being tried. And so this is just to say that in the meantime, while we've been looking for antivirals, other treatments have made it to standard of care. And so we have WHO, as you all know, and I think that are very well aware of, that ever since September 2020, they have strongly recommended the use of systematic corticoids. And then, more recently, we actually had interleukin-6 receptor blockers that have also been recommended to be used in these same patients. Well, I would argue that the combination of corticosteroids and IL-6 receptor blockers really corresponds to strong immunosuppressive treatments. And so I think that we need to think back and we need to ask ourselves, do we really need to give a one-size-fits-all treatment? How about some individualized therapy? Maybe not everyone that is critically ill has no reason to receive an antiviral treatment. Maybe critically ill, seronegative patients for SARS-CoV-2 with high viral loads could actually benefit from antiviral treatments when receiving such strong immunosuppressive treatment. And so I'm going to give a plea for a multi-targeted intervention for severe COVID-19. And now this article was actually already written in 2020, April 2020, but I think that what it states is very important and still holds true today. One single drug will probably not be enough to control or to improve the most severe forms of COVID-19. Antivirals plus blockage of inflammatory pathways are probably needed, and optimization of treatment with antivirals, with steroids, with IL-6 receptor blockers should be used, but should they be used in combination, or should they be used sequentially only after giving antivirals first? And should we consider using other combinations to attain additive or synergistic effects? So I would argue that it is important that we try to move forward, trying to combine approaches through multifactorial design studies. It's very important to better define patient populations at highest risk of poor outcome based on clinical status and also on biomarkers. And these need to be included in inclusion criteria and stratification of studies. And furthermore, we should consider allowing individuals to be enrolled simultaneously to trials that allow different investigational drugs to be tested with distinct targets. And I'm just going to finish by saying, so antivirals for SARS-CoV-2 are not available for all. Antivirals are currently like an empty desert for critically ill patients with COVID-19. Maybe some decisions were taken too rapidly. However, maybe there are some oases where critically ill patients could benefit from their antiviral treatment in association with standard of care. Further studies are needed with more individualized strategies, more effective antivirals, and maybe the MABs are a step in the right direction.
As much as it pains me because I have a question,
Okay, so
we're gonna wait for questions. We're gonna follow the program for the first 6 speakers. So even though I want to ask one, I will not. The next speaker, we've had a change in the program, is my good friend Dr. Marc Leon from France, who's going to speak to us on antibiotics for all. And we have to keep on time because Marc has another talk 10 minutes after he finishes this one in a totally different room.
The Chairman, ladies and gentlemen. So, antibiotic for all, the response is no, despite the guidelines. So, my conflict of interest. So, we have all in mind the 1918 pandemics in which, in the autopsy, very lately, the cause of death were identified as a gram-positive infection due to Streptococcus and Staphylococcus. And so, since this time, there is some strong argument dealing with viral pandemics. There is a bacterial co-infection which should be responsible of death, and so there is a need for antibiotics in this patient, and that was defended by most famous experts in the world. Do we need that in our COVID-19 patient? First, what is the incidence of bacterial co-infection in these patients? If you have a study with all the patients, all type of patients with COVID-19 in hospital, the rate of co-infection in this systematic review is 7%. It's quite pretty low. But that's not ICU patients, that's just patient in hospital patient without severity. In ICU, most studies find the same rate, around 50% of bacterial co-infection in our patient. And on the left of the screen, you can see a study from Great Britain showing a rate at 48%, whereas the normal rate in non-COVID patients is 13%. And in the right of the screen, you can have an Italian study, a multi-center Italian study, and you see the same rate, 46% of patients developing an infection. And as you can see, that's pretty lately during the ICU stay. So the incidence of infection is around 50%, pneumonia for patients in ICU, and for bloodstream infection is around 30%, and it's pretty rare in non-ICU patients. It's a late onset infection, and the pathogens are similar to those you have in your ecology. What are the risk factors for a co-bacterial infection? So first, the severity, probably, when there is all patients, and in this Italian study there was age, need for PEEP, the use of broad-spectrum antibiotic at admission, but that's severity. And I like this study, and in this study they look at several variables. That's a single-center study, and the only factor associated with bacterial infection is the change in chest X-ray, and I think it's a very good message. We can use biomarkers, but as usual, biomarkers cannot provide a very good response, and at the initial phase, if you have a low PCT, you can not start antibiotics. CRP is not useful. And when you use serial biomarkers, each time you have a re-increase, that's pretty in favor of reinfection. If you use adjuvant treatments, if you use low-dose steroids, when you use dexamethasone, for example, there is no risk for bacterial co-infection, for increased risk of bacterial co-infection, and we compare our patient with dexamethasone and those without dexamethasone, and you can see there is no effect. In contrast, if you use interleukin-6 blockers, there is a risk, and that's constantly found in the literature, there is an increased risk of bacterial co-infection with very high odds ratio. So be careful if you use tocilizumab. So the risk factor for your patient to develop a bacterial infection is a clinical worsening, probably, is a change in your chest X-ray, and you can use CT scan if possible. And if you use biomarkers, and if you use serial biomarker, a sharp increase in PCT, or a low ratio between ferritin and PCT are associated with an increased risk of developing bacterial infections. There is no specific risk with dexamethasone low dose, and there is a trend in increased risk with interleukin-6 blockers. So what is the antimicrobial stewardship in these patients? First, there is a global overuse of antibiotics during the successive waves. And in this study from Netherlands, the rate of documented infection, of bacterial documented infection during the first week after admission is 1%. It's not ICU patient, it's just hospital patient, but it's 1% with huge variations between hospital, but the rate of administration of antibiotics is 60%. It's huge, and the duration is pretty short, but we are in Netherlands. I show you here our practice. During the first wave, we developed a bundle providing hydroxychloroquine. That was a mistake, but I'm sorry. We use systematic cefotaxime for 5 days, azithromycin for 5 days after ICU admission, and next we use antibiotic on documentation. We did not use steroids during the first phase, the first wave, and we use only Solimidrol in 4 patients, and that was a failure. In the second wave, we developed a second bundle with no antivirals, no hydroxychloroquine, no systematic antibiotics, unless documentation based on imaging, PCT, PCT ferritin ratio, and the shock state with a need for vasopressor. And we use dexamethasone 6 mg for 10 days for all patients. And I show you here our results. In fact, in terms of antibiotics, and if I exclude the use of prophylaxis, I exclude here the use of 5 days of cefotaxime azithromycin. The use of antibiotic was similar between the two bundles. So the systematic use of antibiotic did not impact the practice. The rate of ICU-acquired infection was similar in the two groups, so the use of a systematic antibiotic prophylaxis did not affect the rate of ICU-acquired infection. The rate of MDR, of multi-drug-resistant bacteria, was increased. That is not statistically significant, but there is an increase, 20% in the bundle 1 and 12% in bundle 2. And we decrease the ICU stay and the number of antibiotic-free days during the bundle 2. The mortality was unchanged between the two waves. So my take-home message, the incidence is variable, but around 40 to 50% of bacterial co-infection in patients with COVID-19. It's late infection during the ICU stage, it's not early infection. The risk factors looks like for all patients, for all non-COVID patients, and you should follow your routine practice and the routine guidelines. And please save antibiotics, do not use them as prophylaxis. Thank you for your attention.
Thank you very much, Mark. Run to the next talk, and I'm happy to introduce now Dr. Anane, who is going to talk about steroids for all or not.
Thank you, Mr. Chairman. Good afternoon, dear colleagues. So, indeed, we're going to talk about corticosteroids for these patients. Here are my disclosures. As you know, observational studies were inconclusive, showing either major benefit or harm. And as you know, several randomized controlled trials suggested that corticosteroids could help surviving. But at least from the recovery trial, one can see that not all patients benefited from corticosteroids, and that clinical severity, in particular the need for respiratory support, was a major phenotype, a major clinical phenotype for being a good responder to corticosteroids. And as you know, if you're not receiving oxygen, if you do not need oxygen supplementation, then you may be harmed by corticosteroids when you are COVID-19 patient. So, and that has been replicated in several trials. I will skip this. As you know, this is a class effect, so whatever the corticosteroids, dexamethasone, hydrocortisone, methylprednisolone, betamethasone, and so on, you can use the one you wish to use because it is a class effect. And also, there is no dose response, so it's not necessary to use more than 6 milligrams of dexamethasone or equivalent. And as you know, the Scandinavian trials comparing 6 to 20 milligrams of dexamethasone in a large cohort of patients with COVID-19 concluded that there was no difference in survival and other outcomes by increasing the dose of dexamethasone. So I can skip this. There is no interaction with age or gender or the duration of disease before admission to the hospital or the ICU. And globally, from randomized controlled trial, the treatment is well tolerated. Obviously, giving all these data and information, WHO recommend this treatment as the routine and standard treatment for patients with COVID-19 who required respiratory support. Having said that, it's clear that the next step is to move on to personalize the corticosteroid treatment in both sepsis, but also in patients with COVID-19 and might be in other viral disease like severe flu. So this is why we have set up a consortium, academic and private consortium, gathering competencies in basic science, clinical science, in also genetics, molecular biology, engineering, and so on, to try to deliver point-of-care tests of corticoresistance for sepsis and for COVID-19. The first step is to start with what is available at bedside routinely. So basically, we merge data from several RCTs on hydrocortisone for sepsis and septic shock, and we use artificial intelligence and several algorithms of machine learning to try to develop algorithms that allow to improve the discrimination of corticosensitive patients among patients with sepsis. And we ended up with a nice algorithm that was published in JAMA Network and that we are now investigating in patients with COVID-19. But obviously, this clinical phenotype and what are the quality of the algorithm you get from artificial intelligence still remain insufficient to accurately inform routine practice. So that has to be enriched, and in particular by adding information from molecular biology, and in particular multi-omic, integrated multi-omic approach, which is basically the aim of the European IROCODES project. So basically, within that project, these data are from Joseph Brigel, who looked at the novel methods of investigating steroid profiling following ACTH test, not only looking at cortisol, but all the steroid precursor. And what he found in this nice analysis, he found that the ratio of corticosteroid over cortisol, when it's lower than 3, it may identify patients among the high-press German sepsis trial on hydrocortisone, a subgroup of patients who markedly benefited from hydrocortisone therapy. So the endocrine approach has to be further explored to enrich the clinical phenotype. Michael Bauer, who is also part of the IROCODES project, as you know, is working on the ratio of circulating interferon gamma over IL-10 as a good indicator of an immune balance that could indicate patients who may be responsive to corticosteroids, and looking again at databases from randomized controlled trials of hydrocortisone in sepsis, he found, and also more recently in patients with COVID-19, he found that basically when your patient has a ratio of circulating interferon gamma over IL-10, a low ratio, these patients are more likely to benefit and to get survival benefit from hydrocortisone therapy. Looking at circulating cells, and for example at monocytes, because monocytes are a very important target for corticosteroids during acute inflammation, and in particular looking at the monocyte distribution width, which is indicating the morphology of the circulating monocytes. The greater, the more activated are the monocytes. And what that work showed, it showed basically that this monocyte distribution width, when it is more than 25, it indicates that the patient with sepsis or COVID-19 might be corticoresistant. And indeed, also lymphopenia and the volume of neutrophils in this study were also strongly associated with corticoresistance. So continuing to look at the circulating cells monocytes, as you know, COVID-19 patients are depleted in NK cells, in dendritic cells, in B cells, and in T cells. The novel finding here is this one. By dividing the patients in corticoresistance versus corticosensitive COVID-19 patients, one can see that among the intermediate monocytes, patients who are depleted in CD16 positive cells are more likely to be corticosensitive when they are COVID-19 patients. As you know, as you may know, GILTs, glucocorticoid-induced zipper, and DUSP1 are two major regulators of the glucocorticoid receptor. So for the glucocorticoid receptor, so to get the genomic effect of glucocorticoids, you need to have GILTs and DUSP1 appropriately expressed. What we found in this cohort of patients with COVID-19 is that a group of patients were unable to express under dexamethasone GILTs or DUSP1 adequately, and thus indicating that the intracellular machinery of corticosteroids effectiveness was altered in this group of patients. So another potential biomarker of corticosteroid resistance in COVID-19 patients. And finally, this is my last slide, preliminary data on transcriptomic data and metabolomic signatures. So basically this is outcome, green survival, red death. This is treatment, hydrocortisone, no hydrocortisone. And one can see here in the green box that there are a cluster of 46 genes that are completely downregulated in patients who survived while receiving hydrocortisone, whereas they are overexpressed in those who died when receiving hydrocortisone. And in reverse, that cluster of genes are highly expressed in hydrocortisone-treated COVID-19 patients who survived, whereas they are downregulated in those who are dying. And for the metabolic, we found 77 metabolites that were discriminating between patients who will survive when receiving hydrocortisone versus those who will die when receiving hydrocortisone. So these were preliminary data that are now being investigated at the European level within the iRecords program. Thank you very much for your attention.
We're going to do questions after the first 6 speakers to keep on time. I can introduce the next speaker in the same way we can introduce the last speaker, which is an unusual way to know what it feels like to actually change the world with one study. So our next speaker is Dr. Tony Gordon from the UK, who's going to talk to us about anti-IL-6.
Thank you, Craig. That's very kind of you to say. Not those slides.
You don't look like Wes Ely.
Okay. So I've been asked to talk, should we give interleukin-6 receptor antagonists for all? To make it clearer, for all severe COVID-19, I think the answer is yes. My disclosures, acknowledgements are here. Just to point out that Roche and Sanofi supplied the drugs into REMAP-CAP, but that is their only involvement in the otherwise academic clinical trial. So why would we consider giving these agents? Well, we learned early on that COVID-19 was an inflammatory condition and that IL-6 is one of those biomarkers in the blood that is raised and certainly raised more in those patients who died, shown in red here. But although it's higher than non-survivors, these levels are actually not that high in comparison to what we see in other critical illnesses. And when you compare them here, you can see the COVID patients are all here, right down on that low line. And in fact, the levels are lower than in that subphenotype, what we've called hypoinflammatory ARDS, according to Karen Calfee and team. And you can see that, in fact, the hyperinflammatory state or sepsis actually has levels that are 1,000-fold higher. So it's not a disease of systemic high IL-6. So why would IL-6 inhibitors work? Well, as we all know, these patients are not the patients who have profound shock and so on we might see in sepsis. The inflammation is generally, what we see is the pneumonitis in the lungs. Those of you who've looked after these patients, these images will look familiar. And so it's not necessarily about tackling the circulating levels of IL-6, it's what's going on in the tissue that may be important. So we set about studying these drugs in REMAP-CAP, and you'll hopefully have seen the publication in the New England Journal. Somehow, I don't know what's happened to the picture as I've come across the channel. It must be a Brexit issue that has disrupted the spelling of New England Journal at the top. But hopefully you'll have seen this publication, and for the sake of time, I'll go through it very quickly. We randomized patients to either 2 active drugs, tocilizumab, 8 milligrams per kilogram. You could get a second dose at physician discretion, or sarilumab, another IL-6 inhibitor. This time it was just 400 milligrams, not weight adjusted, and just 1 dose. It was open label, and the control group was obviously no immune modulation. Just quickly, who did we study? Well, they were sick patients, so they were critically ill, defined as receiving some form of respiratory support in an ICU environment. And that could just be high-flow nasal oxygen, or CPAP, an NIV, or full mechanical ventilation. But in an ICU, and it could be a surge ICU. And we recruited these sick patients early, so they had to be within the first 24 hours of ICU admission or starting their organ support. I won't go through all the other exclusion criteria, but we had this sort of, not in the patient's best interest, which we advise physicians if you thought there was uncontrolled bacterial infection, not to randomize them, but we didn't set specific criteria. Our primary outcome was organ support 3 days. So this is a composite ordinal scale. Any death in the hospital gives you the worst outcome, and on the ordinal scale was labeled as -1, the dark red. Then for those who survived, we count up the number of days that they were alive and free of organ failure. So a high number is good. It meant you recovered more quickly. As you can see, the control group at the bottom, and I think you can see with our first results, tocilizumab and sarilumab, that there is far less red and more blue. Obviously, we did do it quantitatively, and there was about an average of 8.5% difference in mortality in the hospital. For those used to seeing it more in sort of Kaplan-Meier curves, here you can see them for survival up to 90 days, the two drugs independently on the left or combined on the right, and you see a hazard ratio there of 1.6. We did all our odds and hazard ratios that above 1 is good, so there was more survival and credible intervals clearly above 1. It was a Bayesian design. And these patients recovered more quickly. Time to ICU discharge on the left, hospital discharge on the right. You can see that patients got out of the ICU more quickly and went home more quickly. So clear evidence that these drugs were beneficial. And then this was followed up. We reported these preprints in early January, and in February, the recovery trial in the UK, a large trial, as you've heard, well, and you'll know, of course. A slightly different population, included less sick patients. These were hospitalized patients who required oxygen, SATs of less than 92. And they had a criteria that CRP had to be greater than 75. And again, they showed mortality reduction with tocilizumab. They only had the one intervention. Very large numbers, nearly 4,000 patients included. And of course, this evidence has all been brought together in a prospective meta-analysis, agreed a number of investigators to share their data, and came out in JAMA in July. And basically, all of the studies that would agree to share the data included here, and in case you can't read the bottom text, I've enlarged it, odds ratio of 0.86 with confidence intervals clearly below 1, showing that when you look at all of these IL-6 inhibitors, there is an effect on 28-day mortality. People are worried about safety, and I hate to disagree with Mark, especially as he's gone, but he said the literature says there's an increased rate of infection. I'm not sure, and I didn't see a reference on his data, but here's an odds ratio from all of the trials, including the double-blind randomized controlled trials run by industry, which have rigorous pharmacovigilance, and not a single one of them is showing really any concern about secondary infection. And I think this needs to be borne in mind. It's a one-off dose. These drugs are normally used every month for rheumatoid arthritis patients. We were giving 1 or maybe even 2 doses at maximum. So I think the risk profile may be different. And I put this up, this is a small trial, but I think it's important because it comes from India, so a low middle income countries. Does the evidence from the UK apply elsewhere? Well, the trial was too small to show any benefit, but I thought from infection rates, and particularly where things like latent TB may be more apparent than they may be in Europe and North America, again, there were no safety concerns in this population, so just to try and reassure people. What about subgroups? Well, you can see them all here, and I think people need to interpret subgroups carefully. Just because confidence intervals of a subgroup cross 1 doesn't mean the drug doesn't work. Some people have said to me, well, surely, does this show it doesn't work in women? I don't think that is the case. I think both genders should get the drugs. But I thought the one that people always ask about is, well, but surely it's the inflammatory groups, you want to give it to the more inflamed. Well, actually, the point estimates actually are stronger for the lower CRP levels. So I don't think you should use CRP to determine who should get the drug. What did come up, interestingly, in the meta-analysis was the fact that it's this interaction seems to be important, that the earlier trials, the ones that didn't include steroids, didn't show a benefit, whereas the trials where patients were receiving steroids is where the benefit is. And you see very similar effect for tocilizumab and sarilumab. The steroid effect seems to be apparent. It's the combination of treatments where the efficacy is seen rather than just using an IL-6 blocker on their own. REMAP-CAP, its adaptive design, the way it worked was after we saw those results in November, we stopped randomizing patients to control, but we kept on comparing the different immune modulators that we were studying. So now this data is now available just as a preprint. It's not published under peer review yet. But you can see now nearly 1,000 patients with tocilizumab, 10 times more, where have I gone? Saralumab than we had before. Now nearly 500 patients treated with saralumab. And you see very similar signals. We were also looking at anakinra, and as you can see, we didn't see benefit with anakinra in this critically ill population. This is a Bayesian design, so we don't have p-values, we have probabilities, and you see the probability that both tocilizumab and saralumab are better for the control are equal, 99.8% probability. They improve outcomes. And we've actually put in an equivalence analysis, and you see there's an 85% probability they're equivalent. And in fact, it sort of dropped from our threshold of 90%. As saralumab, as you see, the odds ratio is actually slightly higher. And in mortality, a very similar signal. We've combined this data, updated that prospective meta-analysis. The WHO statisticians have taken this new data, put it in a network meta-analysis. Again, this has just gone online on medRxiv as well, went on yesterday, so you can look it up. And it compares the two, and you see very similar effects on mortality for those patients receiving steroids and either tocilizumab or saralumab. And when you compare them head-to-head, the odds ratios are almost identical. They became standard of care the day after we released our preprint in the UK. They were advised, and you'll be aware, as you saw in the earlier talk, they're now recommended both tocilizumab or saralumab for patients by the WHO. And I think having two drugs is helpful as we face drug supply issues around the world. So I will stop there, and thank you to everybody who helped make this possible, and of course the patients and families who helped generate this evidence. Thank you.
Thank you very much for this crystal clear presentation, and we're going to go on still with no discussion, unfortunately, with now Dr. Giamarellos Bourbulis Evangelos from Athens, who's going to talk about anakinra.
Well, thank you very much, and thank you very much for the opportunity of being here with you today and to deliver you some data that have been accepted for publication in Nature Medicine. So, my question, anakinra for all. For those who know me, you know that I'm not an ICU physician. So, in my baseline way of thinking, because I'm coming from the ID world, is that from the very beginning, I was not wishing to treat critical ill patients. I wanted to find a way to early recognize in the general ward who are the patients who are at risk to be admitted in the ICU, and to find a way to prevent their being in the ICU, and also by thinking in exactly the same way we are thinking for infectious diseases, to provide cure to the patients. And I have to remind you that the majority of antibiotics that have been developed and that have been registered the last 5 years by the EMA, they have as target the cure of the patients. So that was my dream for that. So the answer to anakinra for all is not for all. Anakinra is for patients outside the ICU, before the ICU, and allow me to show you how this can be achieved. This is my conflict of interest disclosure. So, what is driving the patient in the ICU? And actually, we know that, and we have experienced that from the beginning of the pandemic, that some of our patients that are hospitalized and they are on oxygen mask or on nasal oxygen, these are the patients for which we are speaking about, not for patients under high flow, not for patients under non-mechanical ventilation. All of a sudden, they deteriorate. And the reason why they deteriorate is because there is a slow release of danger-associated molecular patterns and actually alarmins from the bronchial tree. And when this culminates after a certain amount of time, this leads to unfavorable outcome. The major of these dumps, or alarmins, these are the same, which are released from the bronchial tree, is IL-1 alpha. And also there are other dumps who work through the production of IL-1 beta. And actually what IL-1 alpha and IL beta, they do, they act on their receptor, and this is how they produce inflammation. So if we have a drug that could mimic L1 alpha and L1 beta that can fool the receptor, and we have this drug, which is called anakinra, then we can prevent this to happen. So we are in need of a selection tool to tell us in the general ward who's the patient who's prone to deterioration. And actually, the profile of our patient is a patient who's hospitalized, whose PF is above 150, who's in oxygen mask or nasal oxygen, and who has a biomarker, which is called SUPAR, 6 or more. If the biomarker is there, then that means that the patient is under L1 alpha and L beta attack, and we can prevent that through the use of anakinra. And this is exactly what we did. Actually, this is the test set of how SUPAR in a patient who's on nasal oxygen and oxygen mask can prognosticate what will be the future of this patient. And we have 2 independent validation cohorts coming from the ISICEM consortium, the first that was published in November 2020, the other that was presented a few months ago at the American Association of Cardiology. And you see that a concentration more than 6 here can early predict that 50% of the patients with this high concentration will sooner or later need to be admitted in the ICU, but also in the second validation cohort. In patients at the emergency department, SUPAR was increased far earlier than LDH, IL-6, and ferritin. With this in mind, at an open-label phase 2 program, for patients who had SUPAR more than 6, we started, and they are in the general ward, they are not in need of high flow, they are not in need of mechanical ventilation, we start giving them anakinra sub-Q 100 milligrams once daily for 10 days. So this is what happened to them. 22% ended up in the ventilator in the ICU compared to 59.2% of the comparators, and that was the situation also of the mortalities after 28 days. With these results, I received advice from Covid19 of the European Medicines Agency. And this is what European Medicines Agency asked me to do: a double-blind, randomized, pivotal trial in patients with these profiles, and they are randomized 1 to 2 to receive placebo plus standard of care, and standard of care contains dexamethasone in the patients, or anakinra sub-Q 100 milligram once daily for 10 days plus standard of care containing dexamethasone. And the primary endpoint that I was given by the Covid19 was the 11-point WHO ordinal scale. I want to make clear that this has been accepted for publication at Nature Medicine, and it will appear in the next coming days. This is the flow chart of our study. We had in the full analysis set 189 patients allocated to treatment with standard of care and anakinra, and 405 patients allocated to treatment with standard of care and anakinra. Sorry for the mistake, SOC and placebo, the 189, SOC and anakinra, the 405 patients. So this is the endpoint. Actually, allow me to analyze briefly on that. You see different color bands. And as we move from lower to upper, we move from patients who are fully red, which means that they have died after 28 days, to patients who remain hospitalized, either in the ICU, the full black, or in hospital, yellowish, or who are ambulatory, but they are at long COVID with symptoms, or fully cured. And compare this is the distribution for patients treated with placebo, to the distribution of patients receiving treatment with anakinra. The odds ratio is spectacular, is 0.36, meaning that the likelihood of being better after 28 days with anakinra treatment and to being improved and not to be needed in the ICU is 64%. This is the logistic regression analysis. The covariates entered in the model. We have been asked in our statistical analysis plan by the European Medicines Agency for that, is the intake of dexamethasone, is severity, BMI, and also the geographic region. I would like to stick in the multivariate model. The only variable which is affecting the outcome of the patients in an impressive approach, look at the p-value there, is treatment with anakinra. Regarding what we have found in our phase 2 program, this is one confirmatory analysis that we have been asked by COVID-19. You see again the same finding. 32% of patients who receive placebo, eventually, after 14 days, they will end up in the ICU in mechanical ventilation, compared to 20% of patients receiving treatment with anakinra. And someone could say, okay, much relies on the prognostication tool. How about if I'm in a hospital setting where I do not have SUPAR? What can I do? And that was exactly the question coming from the reviewers of Nature Medicine, and I am grateful to them because they challenged us. And through this, we developed a prognostication score introducing aspartate aminotransferase, the neutrophil to lymphocyte ratio, CRP, and ferritin, above the cutoffs that you see. This is a score. Each of this provides 1 point. And you see that patients who score 2 or more points and they are getting treatment with placebo, they have an odds ratio either to die or to develop ARDS after 28 days, which is 8.64, and this decreases significantly to 2.63 after 28 days. So this score can very well replace SUPAR. And so the question is, who is the patient? I go back to the question, anakinra for all. No. Anakinra is for patients who lie in between these 2 stages. Here are the critical ill patients. We do not wish to have our patient here. This is the general ward. And we want to identify who of these patients who lie here, and we identify that through the use of biomarkers, can receive benefit in a type of prevention strategy to avoid ICU admission. So I would like to finish my talk by trying to translate this difficult WHO CPS point scale by the conclusion that adding anakinra to the current standard of care makes 2.8 times more likely to improve overall clinical status, which means that for every 2 patients who receive placebo, we get 3 more fully recovered with anakinra. Among patients who are at long COVID, they are decreased from 5 to 3. From patients who remain hospitalized, either moderately or severely, we decrease them by half. And also, among patients who will eventually die, we will decrease them by half. Thank you very much for your attention.
Our final speaker in this part, and we're going to take a few questions after this. When I first met Wes Ely, I said to him, you should write a book called The Death of Benzos because of his profound change in how he handled delirium, and now I might suggest to him for the first time publicly, you might want to write a book, at least a pamphlet, The Rise of Baricitinib. So, JAK inhibitors.
That's a very interesting comment you just made, because on my computer, I have a folder called The Death of the Benzo, based on your suggestion to title the book. But I ended up, because of the editor, changing the title of the book to Every Deep Drawn Breath. And that is a book, I wouldn't have even mentioned it, but you brought it up. It's coming out next week via Scribner, called Every Deep Drawn Breath. It's not a memoir, it's a book of narrative nonfiction about patients, for patients, and every penny that comes from the sale of that book is going to go back into a fund for patients and families. So it's an effort to raise money for survivors of critical illness. Anyway, the question here is JAK inhibitors for all. My name is Dr. Wes Ely, and I'm at Vanderbilt University in Nashville, Tennessee. And I'm going to present to you the data from our new Cove Barrier study, which will go live today on Lancet Respiratory at 5 p.m. My disclosures are that this was a project supported by Eli Lilly. I received no money for any work. I insisted that I would receive not a penny for this work. I do disclose honoraria for CME programs carried on by other companies, Pfizer and Orion. I do not own any stock or have any paid consultancies with any pharmaceutical companies. The hypothesis behind JAK inhibitors, in this case baricitinib, which I call Bari, B-A-R-I, Bari, is that this drug, JAK inhibitors in general, but this drug specifically, have potential antiviral effects and well-established anti-cytokine effects. The key characteristics of this drug medication is that it's a JAK1/2 inhibitor. Multiple cytokines signal through the JAK-STAT pathway. It's a tablet that can be administered once a day, and that's an advantage because you could stop it if the patient was clearly better. The drug has a short half-life of only 12 hours and is quick to wash out. There are few drug-to-drug interactions because of a low CYP inhibitory activity, and it has a very long-established safety profile, mostly with diseases like rheumatoid arthritis. Very early in the COVID pandemic, this publication came out from Richardson in Lancet, whereby benevolent artificial intelligence was used to look at the world's data for the purposes of evaluating hundreds of medications for repurposing for use in COVID patients. As you see on the bottom here, baricitinib was identified as the primary agent, the top agent that is, whereby you would have a drug that would work at viral entry, endocytosis, and cytokine signaling. And it was this that caused other investigators to begin to do trials with baricitinib. An investigator named Vince Marconi at Emory with his colleagues published a case series in CID, which had 15 patients who had moderate to severe COVID, and 11 of them did unexpectedly well. So this kind of led more into the hypothesis that this should be tested. As you know, baricitinib has very robust anti-cytokine activity in that it normalizes cytokines such as IL-6, interferon, IL-10, and others. These cytokines are obviously involved in myeloid dysregulation, endothelial inflammation, which is a huge problem for our COVID patients, and an antigen presentation. This is the cover shot of today's publication, which will come out in Lancet Respiratory at 5 p.m. The study design was as follows. This was a double-blind, placebo-controlled investigation whereby patients were given either placebo or baricitinib 4 milligrams once daily for up to 14 days. The patients were hospitalized, if you just go down the right here, hospitalized COVID patients who had evidence of pneumonia or active COVID infection other than pneumonia at OS 4, 5, or 6, and at least one increased inflammatory marker. We excluded people who were already on a ventilator or who were in ECMO, but I'll go on to tell you that we've now studied ECMO and ventilated patients in a stub investigation. And we had a protocol amendment noted down here, whereby soon after the initiation of the study, we realized that people who weren't on oxygen were less likely to benefit, and so we began excluding people who were not on any oxygen in the hospital. We eventually went on to add OS 7 to a double-blind, placebo-controlled randomized trial, which I will not show you the data of today, but which are already submitted for peer-reviewed publication. Patients in this investigation were given standard of care in addition to baricitinib. So 80% of the patients were on corticosteroids. 90% of those people on steroids were on dexamethasone. And they were also all given venous thromboembolism prophylaxis. This investigation was carried out at 101 centers around the world in 12 different countries, Asia, Europe, North, and Latin America. There are a lot of data on these slides, so I've taken it upon myself to highlight in red, bold, the things I think will make it easier for you to follow along and for us to get through such a short presentation. But obviously, all of the data will be available to you free tonight. It's open access tonight at 5 p.m. So 90% of the patients in this investigation were enrolled either on oxygen or on non-invasive masks or high flow. And as I said earlier, 80% were on corticosteroids. The primary endpoint was whether or not you had an advance in your severity of illness. I actually consider this one of my greatest failures as an academic. We just did not think that we would have enough power to evaluate mortality, and so we hedged on OS ordinal scale. In this case, there was a 3% less progression as defined by this composite endpoint of baricitinib with standard of care versus placebo, but this did not meet statistical significance. You see the p-value here is 0.18. And there are a lot of things that go into progression on ordinal scale. Arbitrariness on when do I intubate versus I keep somebody on a mask. When do I intubate versus continue high flow? And the other thing I think that may have been a reason why this ordinal scale didn't work for us in terms of outcomes, or why the drug wasn't shown, maybe it's just true, but it could also be that about a fourth of the patients progressed in their ordinal scale within 24 hours of getting on this medication, placebo versus bari. And that's a pretty short interval of time for a medication to make a difference. In the end of the day, the hardest endpoint that we have in COVID is mortality. And these are the 28-day mortality data. In this investigation, baricitinib yielded a 5% absolute risk reduction in death, which was highly significant at a p-value of 0.0018 with a hazard ratio of 0.57. As you go out to 60 days, you can see that this mortality benefit held at, again, an absolute risk reduction of 5%, p-value of 0.005, hazard ratio 0.62. In one sense, you can say that once this disease was started, the train was leaving the station. Baricitinib didn't shut the train down immediately, but it prevented the train from going over the cliff to death. The sicker the patient, the higher the absolute risk reduction in death. Here you can see the subgroup of just those who were on BiPAP or high flow, and you can see a very nice differentiation between survival between placebo and baricitinib with an absolute risk reduction of 10%. And if you look at this forest plot, you can just see that the point estimates are all on the side of favoring baricitinib over placebo, and the only ones that have wide confidence limits are actually very small subgroups. Turned out there were fewer patients enrolled in Europe. OS5 was a small group, and then also remdesivir use was actually not a huge group. I show this just so you can look at number needed to treat. The overall number needed to treat in this study to save a life was 20. So 1 out of every 20 people treated with baricitinib, a life was saved. And that number drops into the single digits for the OS6. Those are people on a BiPAP mask or high flow. I told you that I would reveal to you what we learned about the mechanically ventilated and ECMO patients. So again, about halfway into this study, we said, well, we're excluding all these people. Why don't we just start enrolling them and double-blind randomize them? And so we have, and the data are now submitted for peer review. What we found in that group, which was 100+ patients, was that the number needed to treat to save a life was 6. The absolute risk reduction was over 15% in death. In terms of safety, these are the largest safety data to date, to my knowledge, of adding an immunomodulatory agent on top of corticosteroids, and there were no delta. It was the same whether it was measuring infections, VTEs, or myocardial events, including stroke. These are more data on the safety. There's just no difference between the two groups. So in conclusion, baricitinib in this 1,525 patient double-blind placebo-controlled trial from 101 centers in 12 countries did not stop COVID patients from progressing to a higher ordinal scale. There was a 3% difference at a p-value of 0.18. It did reduce 28-day all-cause mortality by 5% absolute risk reduction, number needed to treat of 20, and 60-day mortality as well. It did not increase adverse events, including infections, clots, major adverse cardiovascular events, and it represents an obvious adjunctive agent to corticosteroids, I think, along with the IL-6 blockers, which we've discussed earlier. And I've been using this medication for the past several months and have yet to find, anecdotally, a problem with its use. I think that this is great, in accordance with the previous investigators, that we now have options in addition to corticosteroids. Thank you.
Congratulations. Please stay on the floor, and the other speakers, the other previous 5 or 4 speakers, Mark left, are invited to come to the floor too. And those who have a question, please line up at the microphones. We have 10 minutes, I think.
Yeah, and I'm going to take the first question for the moderator. And by the way, I have to disclose, I've advised the WHO and I sit on the NIH COVID guidelines in the United States. So my question is for Drs. Gordon and Eli, although I have so many questions for everybody. You both presented very impressive studies on tocilizumab and baricitinib. Which should we use? Should we use both? You both have compelling data. You have not combined your compelling data, though everybody gets steroids. If I have a patient today in ordinal scale 6 or ordinal scale 7 in my ICU, I mean, I understand I'm not in the United States, who should I treat today? Which drug, if there were no drug shortages?
It's an excellent question and a difficult one. Obviously, I've just seen the data now. It looks very impressive. We're familiar with using IL-6 inhibitors, so that's probably what I would use right now. But I was just discussing this with Lenny there, who's part of REMAP-CAP. She said, are we going to have to randomize now the 2 drugs and find out the answer? Because I'm not sure you can tell from looking at that. There may be less sick patients included, but that was a recovery trial, had less sick patients as well. So I think it's very difficult.
Yeah, I also think this is a great problem to have, right?
Yeah.
I think this Cove barrier study, these data are extremely solid. I regret picking the ordinal scale as the way up because I think there were too many inter-individual practice behaviors that can affect the ordinal scale going up to intubation. But what I would tell you is that one of the reasons that I've been enjoying baricitinib lately is because I can use it as a once daily drug and I can stop it when the patient is clearly better around day 8, day 9 if I want to. I don't do that all the time, but in other words, the immunosuppressive characteristics aren't as long acting. So that's one difference between the 2 groups. I don't think that's a game changer. The other thing is that thankfully, this is one of these great partnerships with industry in that Lilly is actually making baricitinib available free to lower middle income countries. So patients in India, Haiti, many countries in Africa are all going to have baricitinib free, and I think that's an easy way to use the drug PO. It also can be crushed and put down an ET tube, put down an NG tube that is, so patients are intubated and can't swallow. So I think that reduces some of the limitations to administration of the drug in hard-to-reach countries who don't have any money. But again, I think these are beautiful data. This is a great problem to have, and luckily we have two drug therapies. I'll leave you one more mechanistic thought. The JAK inhibitors have a very broad immunomodulatory effect, and apart from just IL-6, you saw an entire list of other things that they hit, and I just think that since IL-6 isn't the entire storm, there might be some advantages, and maybe that's why we had such a large mortality benefit in Cove barrier.
Nicole Jefferman from Amsterdam. I have a question for Dr. Gordon. Could you reflect on the comparison between the different anti-IL-6 blockers? Because I have the impression that sarilumab consistently performs a little bit better in the trials that you showed.
So I think the evidence is they're equivalent. I know I pointed out that the odds ratio was very slightly higher, but I mean, I think this is just the vagaries of data that one is slightly higher than the other. I think people, I think keep it simple. There could be very slight differences between them, but they both work in the same way on the molecule. They may have different binding properties. But I would really use either one. I think they are, from what we've seen, interchangeable. This drug supply issue is a big problem globally. So I would use whichever one you have in the cupboard. And if you run out of both of those, then maybe baricitinib and Imatinib.
There we go. One last question for my co-chair.
Sure, for Dr. Heitz. I told you I was going to have one. I mentioned before my conflict of interest in that I've worked with the WHO and the NIH COVID guidelines, and about the only place that they totally diverge is remdesivir. The WHO says fairly strongly, do not use remdesivir, and the NIH guidelines say to use remdesivir, not necessarily in ordinal 7. Everybody looks at the same literature, and yet come to widely differing opinions. What's your take on patients in ordinal fiber and such. Should we be using antivirals? Should we not be using antivirals?
Antivirals or remdesivir? Sorry.
Remdesivir.
Okay, sorry. Okay. Remdesivir for me has no place in our therapeutic arsenal. And so we also have an accepted paper in Lancet Infectious Diseases with results from the Discovery trial, also showing very clearly that there is no clinical effect on outcome for patients, but also there is a very detailed analysis of viral loads, and there is absolutely no effect that has been shown. And I think that this goes just more in line with already all of the pooled study from the Solidarity trial that already had a huge number of patients that participated. So I do recognize that there were other randomized controlled studies showing that there were maybe differences in the fact that patients took a longer time, or they were able to avoid ventilation for a longer time, and there were certain differences. But clearly, I think that when you put everything together, for me, there's no antiviral effect. I think that's what the evidence goes towards showing. And I would say that there's currently a meta-analysis that's going to be done with individual patient data to really even go further, to really make sure that there's no subgroup of patients that could really benefit from any kind of activity of remdesivir. But so my take on it is that remdesivir, yes, in vitro had shown activity even in macaques, but probably it doesn't have a strong enough antiviral effect, and that's where MABs currently anyways, when you look at the data from already animal studies, they have a much stronger antiviral effect, and I think that that's why it's actually translating into a much more potent antiviral treatment for patients.
Thank you very much, and I thank all the presenters, and I'm happy to introduce my colleague and good friend from Leuven, Geert Melford, who's going to talk about the effect of reconvalescent plasma in COVID patients.
Thank you, Michael. So the title of the talk, because everybody got the same title, is Convalescent Plasma for All, but what I will mainly do, or at least half of my talk, will be the results of our Belgian multi-center Dawn plasma trial, where I was a principal investigator. This trial was funded with public money by the Belgian Healthcare Knowledge Center. So what was the rationale in the beginning, and why so many convalescent plasma trials that you've seen in the meantime? Well, in the beginning, of course, there was no evidence-based antiviral therapy. It's a therapy that is potentially to be used in many settings, because with the large number of affected people, there's a large number of potential donors. And also it's a therapy that can be made available in resource-rich areas such as this country, but also in more resource-poor settings. And there is a long experience of the therapy in earlier pandemics, which have not so much shown efficacy, but at least a good safety profile. The earlier SARS pandemic unfortunately resulted in no RCT, because the pandemic was over before they could do that. There's some small observational studies pointing to a possible success, and so maybe the therapy could offer a form of passive immunization to a COVID-naive patient who didn't have the time yet to make his own antibodies. So maybe the borrowed immunity could influence the course of these patients. And so preliminary reports like this, where 5 Chinese patients were treated with convalescent plasma and then apparently made a faster recovery than, and a decreased viral load than what you would have expected. So there was finally the opportunity here with the pandemic that never seemed to stop to do the large RCTs. And so there's a lot of randomized trials that started early in this first wave worldwide that had some difference. So the devil is always in the details, with antibody concentration that were different, with the number of units that were given, with timing, with population, with different settings, etc. And I will go over a couple of these trials. For instance, the early Placid trial in India, about 500 patients. They gave 2 times 200 mLs of convalescent plasma and had no influence on 28-day mortality or progression to severe disease. There was the Chinese study published in JAMA, 100 adults. didn't reduce 28-day time to clinical improvement. There was a Dutch study that was halted prematurely because they saw that actually the patients had higher or comparable concentration of antibodies than the plasma that was donated. The Argentinian Lipster trial, actually a positive trial, where they saw in elderly patients who were only symptomatic for less than 48 hours, so very early. They gave high IgG level plasma 1 dose within 72 hours after symptom onset, and they saw less progression to severe respiratory disease in the plasma group. A US study where there was no effect. The Simonovic trial where there was no significant difference, and then last week there was another trial published in New England that was also negative, and I can go on because there's more trials than this that have been done. Some early meta-analysis have been done with some of these trials, and like this by the group of also John Ioannidis, who participated, but mainly Lars Hemken's group. So there was no effect of the trials published until then on mortality, on hospital length of stay, or on patients on mechanical ventilation. And then the large platform trials who also have studied the intervention. First of all, the recovery trial, 2 units of high titer IgG plasma, more than 10,000 patients, and the study was prematurely stopped for futility because there was no significant effect on the composite endpoint. In the same paper, there was also a meta-analysis which was, of course, hugely influenced by the largest trial, which was recovery in itself, which showed no effect for the intervention. And then REMAP-CAP also had a plasma arm where there was no effect on the outcome of organ support 3 days, nor on any of the secondary outcomes. So why would I present our own Belgian trial here then, down plasma trial, apart from the fact that it's published last week? So it's interesting for me as the author, of course, but it's also interesting for you. Well, there's some findings in our study that, well, first of all, it's the first time that the study is presented in public, but also there are some findings that may be interesting in understanding why the therapy does not appear to work. So what was the design of the study? We did a Belgian multi-center trials in 22 sites. We included hospitalized patients. It was an open label study, so it was not blinded, and our primary endpoint was a proportion of patients alive and free of mechanical ventilation at 15 days, and then secondary endpoints were aligned with WHO standards. We had a 2-to-1 randomization, so 322 patients were planned to be randomized to plasma plus standard of care, whatever the standard of care of that moment was. 161 only had the standard of care. What is, I think, unique about our trial is that we aimed for high neutralizing anti-50, so neutralizing antibodies, more than 1/320. This was assessed in the donor, so the donor was called, they were screened through a web form, and then when they fill in 7 questions, when they were okay, they were called to donate, and then antibodies were tested, and only plasma of those donors with antibody titers of more than 1/320 were used for the study. And we used 4 units of that plasma, so in 2 gifts, 2 times 2 units. And the intervention was done early in hospitalization, so within the first day. So these 3 properties make this study maybe unique, especially the dose, which is, to my knowledge, the highest dose that was given in any other study. So as I said, the study was published end of last week online in the European Respiratory Journal. And so we have finally randomized 489 patients, but 6 had to drop out early because of early withdrawal. So we ended with 483, which was planned. 320 in the plasma group, 163 in the standard of care group. Median age was comparable. Proportion of male gender was comparable. Most of the patients were obese, and the BMI was comparable in both groups. They were sick, so on room air, 90%, 91% saturations, 88.8%, almost 90% of patients got oxygen upon randomization. Most patients were randomized when they were in the normal hospital wards, 15% were in the ICU. Comparable proportion of patients who received corticosteroids, and a comparable proportion of patients who received anticoagulation under a form of low molecular weight heparin. And these is the intervention, what we intended to do. So we wanted to have the intervention and the randomization early. So patients were admitted to the hospital median 6 days after symptom onset, and were randomized within 1 day, and the plasma was given within 5 hours after randomization. So we think this is quite successful, and this is the way we intended it to be. We transfused median almost 900 milliliters of plasma, which, as I said, is probably one of the highest doses of any of the studies. And 80% of our units that we transfused had the pre-specified high titer of 1/320. But in spite of that, this study as well has shown no effect on the primary endpoint of proportion of patients alive and free of mechanical ventilation at 15 days. Also at 30 days, there was no effect. There was no effect on mortality or on alive weaning from mechanical ventilation at 30 days. There was also no effect on the secondary outcomes. There was also, in none of the pre-specified subgroups, was there any significant effect except for age. The age below the median age of 62 years had a borderline significant p-value of 0.053. But what was maybe most surprising, and as a second interesting part of our study, apart from the fact that we gave a lot of plasma, even this high dose of plasma was not able to influence the natural course of antibody titers in these patients. So there was no difference in the natural course of antibody titers between the patients who got plasma versus the ones who did not get the plasma. And the neutralizing antibody titers in the blood did influence the viral load, but this was not influenced by the intervention. So to conclude, 4 units of this high antibody titer plasma did not influence the natural course of neutralizing antibodies, did not reduce the need of mechanical ventilation, did not impact on any other secondary endpoint, and I have not shown you the safety endpoints, but there was no problem with safety of the intervention. Of course, this was an open label study, and even while it was early in hospitalization, it was maybe relatively late in the course, as almost 1/3 of the patient already had neutralizing titers comparable or higher than the plasma that was transfused. Mortality in Belgium for hospitalized patients was relatively low, so maybe our findings cannot be extrapolated to other settings where the mortality is higher. And then if I have 30 seconds, I will, so patients on rituximab were excluded from our study because because of this B-cell depleting drug. We did study a small series of patients observationally on rituximab, where we gave them convalescent plasma. This was published in the British Journal of Hematology earlier this year, and we did see in these 5 patients a fast clearance of symptoms and clearance of viral load as well in the nose. So maybe these patients can still be excluded from, well, there's still a place for plasma in this group of patients. And then to stop, we will participate also in the Compile initiative by New York University, where we will pool our data together with other international trials and maybe find signals in certain subgroups that might be positive. And with that, I would like to thank you for your attention.
Thank you, and we'll take questions after the next set. So our next speaker, who I'm going to meet for the first time, good to make a new friend, is Sakar Yasir, who will speak on Camostat mesylate for all.
Thank you very much, Mr. Chairman. Good evening, everybody. So I'm going to speak about some sort of an exotic treatment. Probably you didn't hear about this before. I don't know if you are well aware of the compound. So Camostat mesylate was developed in Japan in 1980s. It has been used there at a wide scale in patients with chronic pancreatitis and those with the reflux esophagitis, with the main mechanism of action being a protease inhibitor, a serine protease inhibitor of the TMPRSS receptors, the transmembrane receptors present on the surface of the cells and expressed in a lot of tissues in our body. So Camostat is by itself an inactive compound. So after oral ingestion, it becomes metabolized to an active metabolite within a couple of minutes and slowly metabolized after 4 to 6 hours to another inactive metabolite that doesn't exert any biological activities on the cells. So coming back to the TMPRSS receptors, so TMPRSS is a family of receptors, transmembrane serine proteases, that are widely expressed in epithelial cells, has been shown to facilitate viral entry in cases of influenza viruses and SARS viruses and MERS-CoV viruses. Let me explain why the drug was available in the Middle East countries during the early days or the early month of the epidemics of the COVID-19 epidemics. What happened is actually that these receptors cleaves the S-spike proteins of the SARS-CoV, which leads to adhesion of the viral on the cell membrane, facilitating the viral injury and entry and the subsequent intracellular replication of the virus. So that can be the mechanism of action of the TMPRSS receptors facilitating viral injury and replication of SARS-CoV, inducing a potential or a possible effect of Camostat mesylate, which is an inhibitor of the TMPRSS as a therapy in patients with COVID-19. So the TMPRSS, as I said, is a family of various receptors, including TMPRSS2, TMPRSS11D, among other receptors, which are expressed in a lot of tissues, especially the TMPRSS2 and the TMPRSS11D, as you can see here from these data, are expressed widely on the lung tissues. Here's the TMPRSS2 and here's the TMPRSS11D. And these receptors have been shown in quite clear experiments that they are implicated in the viral entry of the SARS-CoV. So as you can see here from this experiment, for example, that the different type 2 transmembrane serine protease can activate the SARS-2 in transfected cells. So that was an experiment on tissue culture. And in the same experiment, the authors have also looked at whether the activation of SARS-CoV by the TMPRSS can be suppressed by Camostat mesylate. And indeed, these receptors have been effectively suppressed by Camostat mesylate in addition to its active metabolite, which is available commercially under the name of FOI 251. Again, you can see here from this study that Camostat mesylate and its active metabolite inhibits the SARS-2-driven cell entry with comparable efficiency, and that means that it may be effective in determining or reducing the viral load by preventing viral replication and viral adhesion to at the cellular membrane level. This have been confirmed also in another experiments, not only with Camostat, but also the nafamostat, which is also another inhibitor of the TMPRSS2 receptors. Clinical data are very scanty, actually, on the compound. As I said, it's a drug coming from Japan, and the rationale behind using the drug is well known, but the use of the drug and the experience of the drug, especially in Europe and the US, is not widely extended. So we don't have a lot of data on that. The initial case reports that we can see here from this case series of patients with severe COVID pneumonia, showing that using Camostat therapy in patients with COVID pneumonia admitted to the ICU would be associated with a reduced severity of illness, as evident here from the reduction in the SOFA score over time after treatment with Camostat mesylate. If we think about the mechanism of action of the drug, you may actually expect that it would work if you give it early during the course of the disease, because you are actually tackling the process of viral adhesion and viral entry and viral replication. But this study was actually performed, or this case series was actually performed in patients admitted to the ICU. So Camostat can have also, in addition to inhibition of the TMPRSS2 receptors, also through the inhibition of the TMPRSS family immunomodulatory effects that may also explain why this compound may also be helpful in treating patients with advanced severe disease forms. So that was a series of cases, that a cohort that we have from our colleagues from the United Arab Emirates. It's quite a large cohort of patients admitted to the ICU in an ICU of a hospital which was devoted during the first wave of COVID-19 to treat COVID patients. It was actually an unstressed ICU. So if you know about this country, it was actually a country that was affected largely by the virus during the first wave, but it has a very good infrastructure of intensive care units and so on. So they converted complete hospitals to ICUs with a very high infrastructure and high expertise in treating ICU patients admitted with COVID-19. So the mortality rate of this cohort was around 20%, but the rate of mechanical ventilation in this patient was above 50%. So that was indeed a cohort of severe patients with COVID-19 pneumonia. Some of these patients have received Camostat therapy and others did not, so it's not really a randomized trial. But it's worthy actually to look at this sort of data in the absence of large randomized controlled trials to try to understand whether some compounds would work and in which subgroups would these medications work and exert beneficial functions in patients with COVID. So in this cohort, as you can see, most of the patients have received some sort of antiviral treatment, mostly also the favipiravir. And also some of these patients have received immunomodulatory therapy in the form of hydroxychloroquine, because it was during the first wave of the epidemic. So a lot of people have used this at that time. Not anymore, but that was the practice at that time, in addition also to steroid therapy and tocilizumab therapy. And surprisingly enough, if you look at the mortality in patients who received Camostat, you can just see that the mortality in the control patients who did not receive the Camostat was 3 times higher than patients who received Camostat therapy, despite of the fact that they were very similar at the baseline. Patients here were a little bit younger, because that's the demography that they have there in the UAE, with mostly patients, young patients admitted from several cultures, mostly Asiatic cultures also. In addition, the severity scores were similar between these patients, but by the end, patients who received Camostat therapy have survived more than patients who did not receive this therapy. Even after you adjust for the confounding factors that may be related to the severity of illness and concomitant medications, you still have a very good signal towards a beneficial effect with treatment of Camostat. Even if you do a propensity score matching, still Camostat therapy was associated with a very low risk of death in these patients. Again, there are a lot of controlled trials. I think that the research in this compound is a little bit hanging behind. We have more than 10 randomized controlled trials. Only one of them was actually published recently. I would speak in the last few minutes about it. So it was a randomized trial in patients with symptomatic COVID-19 infection with a hospital admission within 48 hours in 8 Danish ICUs, randomizing patients in a 2-to-1 fashion to receive Camostat methylate or not. And of course, that's a slide that you can see of most of the trials on critical care medicine, So the therapy showing no effects, even if you look at all the subgroups of patients. But again, and and of course also it did not affect the progression of illness. So the question, why should these patients do not benefit from Camostat? Again, I would come back to the pathophysiology, to the mechanisms of action of this drug. So the TMPRSS2 receptors are actually not the main or not the only way of viral entry, and is not the only way of the interaction between the cells and the antiviral medications. So we have also the Ace Ii receptors, which is also well established in the mechanism of entry of SARS-CoV-2 virus. So you may not expect that Camostat mesylate alone would actually make the difference. It should be also the concomitant therapies that you are using, especially antiviral treatment. Again, in this cohort, if you can look in the differences between the randomized groups, you can see obviously that patients who were assigned to both groups actually were very severely ill at first, because most of them required mechanical ventilation and need 1 minute. And of course, these patients also received the Camostat mesylate therapy a little bit late after the onset of the disease, after 8 days of the onset of symptoms. So maybe it was a little bit too late administrating patients in these patients. You can see here also from this very small subgroup where the viral load was measured, that patients who are actually admitted or measured after onset of the disease, they have a very high viral load. These patients could have actually benefited from the use of Camostat mesylate therapy. The main concern is the risk-benefit, so my conclusion would be that Camostat mesylate can be useful in hospitalized patients with COVID during the early as well as the late phase of the disease trajectory, waiting for the results of multi-center trials. The current evidence that do not support the routine use of Camostat, but the relatively low risk profile of treatment may justify considering the compound in these patients according to availability. Camostat may not be expected to serve as a monotherapy, and additional antiviral treatment should be considered if you are planning a trial on that. Thank you very much. So I'm going to jump to another talk, so sorry for that.
Thank you very much, Dr. Zacher. I'm now going to introduce from Amsterdam Dr. Nicole Jefferman, talking about Imatinib for all. The floor is yours.
Thank you for the introduction. I don't have any conflict of interest. And Imatinib for all COVID patients, well, I think at this point in time it's too early to say. We only have one trial. Probably not for hospitalized patients only in need of oxygen on the ward, but it's very promising therapy for the critically ill patient. So nobody will argue with you if you say that COVID is an endothelial disease. Although there's been some discussions whether or not you can infect endothelial cells directly with the virus, as if you want to try and do this in the lab, it seems that it's pretty difficult to establish that. But no doubt there's endotheliolitis, and this occurs in the lungs, but it also occurs in other organs. You can see here the histology of the kidney and the gut, and you can see here the infiltration of neutrophils into these organs. And the staining that you see there, this caspase 3, that stains the vessels, and you can see the endothelial cells coloring up brown, and this means that they go into apoptosis, or in other words, the endothelial cell die. So what is actually happening during COVID? I made a cartoon of this. This is the vessel wall, and the endothelial cells are tightly linked together with a structure that's called tight junctions. So when SARS-CoV enters the endothelial cell wall, there is activation of the immune system with the immune cells responding, and they express cytokines, and this leads to an expression of these adhesion molecules. And then the neutrophils then tether along, they adhere to these endothelial cells, and then a close interaction starts. And this actually results in loss of tight junctions and increased endothelial permeability. And then when the disease progresses, when it becomes more severe, the endothelial cells die, they shed their toxic content into the circulation, termed DAMPs, and this attracts even more neutrophils, even more cytokines, etc., etc. So the net result of all of this is endothelial permeability with leakage of the fluid to the interstitium, edema, and then ARDS, AKI, etc., etc. So this is what's happening in COVID. So there is Imatinib. We know this drug. It's a tyrosine kinase inhibitor, and it inhibits the BCR-ABL, which is an oncogene, and thereby there's inhibition of these tumor cells, and that's why we use it in patients with chronic myeloid leukemia. And actually, this is Jurjen Amann. He's a very bright biomedical scientist from Amsterdam, and he, together with late Professor Groeneveld from Amsterdam, he discovered a novel pathway of the effects of Imatinib, and identifying a specific RAC pathway enabling an inhibition of another tyrosine kinase, and this actually regulates the tight junction connection. So there it comes of interest to COVID. And what they actually did was demonstrating that here you have your endothelial cells, you see disarrangement of the tight junctions, so a loss of the contact of the endothelial cells together, as well as a loss of contact to the endothelial cells to the basement membrane. So also there's a problem. And if you then treat with Imatinib, you establish the tight junctions as well as the attachment to the basement membrane and the extracellular matrix. So Jurjen Amann and investigators, they did all the preclinical work investigating the effects of Imatinib in LPS-induced ARDS and in LPS injected intravenously, so in endotoxemia. And in all of these preclinical models, Imatinib seemed very effective. So then they effectively treated a patient diagnosed with vascular leakage syndrome, which wasn't an ICU patient, but this was an outpatient suffering from this severe illness, and they tried various medications and none of them worked. So as a last resort, they figured, well, we have this drug, we know that it works preclinically, let's try it. So that's what they did. So they started treatment of this patient in the outpatient setting, and they measured the pulmonary leakage index, which is a great test by which a radioactive compound is injected intravenously. And then if you put probes on the chest, you can actually measure the amount of radiology or radioactivity on the chest, and thereby you can calculate the amount of fluid that is leaking, especially from the lungs. So using this technique, the pulmonary leakage index, they saw that treatment of this patient resulted in a dramatic decrease of the pulmonary leak index together with a decrease in the body weight and an increase in the albumin within the circulation. So this was a great result, and they were actually preparing for trials in ARDS to trial this component. And then COVID came along, which, as already been alluded to, is actually a great intervention or a great situation to perform a trial. So this trial took place in all these hospitals in the Netherlands. It's only in a single country study. And patients were included with proven COVID infection who were hypoxemic, with a saturation of less than 94%, so in need of supplemental oxygen. They were randomized 1-to-1 to receive Imatinib or placebo, a tablet of Imatinib or placebo for a trial duration of 10 days. And then the primary outcome was time to liberation of all oxygen support. And the amount of patients per arm was 193. So this is the enrollment. We screened over 800 patients. A lot of patients were excluded due to not providing informed consent. I cannot give you detailed information about why such a high amount of patients declined participation in this study, but this is how it went. So 400 were enrolled and not so much excluded. And these are the baseline characteristics. I hope you can read it, but in general, it's your average, let's say your average COVID patients, predominantly male, a little bit overweight, hypertension, cardiovascular disease, COPD. and I think of importance is that the two groups did not differ in the time of where they were when treatment was started. So it was day 10 from start of disease symptoms, which was equal in both groups. Again, this was done in the first wave, so comparable to other studies, the standard of care differed from what we do now, in a sense that dexamethasone was administered to more than 70% of all these patients, but also some of them received remdesivir, and hydroxychloroquine was also given in a minority of patients, and none of them had received anti-IL-6 antibodies because we didn't know that at that time. So here's the primary outcome. There is no difference between the groups related to the primary outcome, which was the discontinuation of all oxygen. And I guess, well, if we knew now, if we knew then what we know now, we wouldn't have chosen this as a primary outcome, because we know now that COVID patients, the time that they need supplemental oxygen can carry on for weeks on end. So probably we would have measured something else as a primary outcome, but this was the choice at that time. So the primary outcome, no effects there. What about the need for mechanical ventilation? Imatinib also did not reduce the need for mechanical ventilation, but I'd like to invite you to look more closely to these Kaplan-Meier curves, because it seems here that the need for mechanical ventilation is a little bit lower for imatinib, but when the trial drug was stopped at day 10, there seems to be a catch-up phenomenon there, if you will. But in patients requiring mechanical ventilation, the use of imatinib reduced the duration of mechanical ventilation by 5 days. And another interesting finding is that in the most severe patients, imatinib reduced mortality. And this was significant in the unadjusted group, but also when the groups were adjusted for baseline imbalances, the difference remains. So this is an important secondary outcome of this study. So equally important, imatinib is associated with cytopenias. The most important one is thrombocytopenia, but that happens when you take imatinib for prolonged duration. So here there were no differences at all between the two groups, so no worries there. So in conclusion, imatinib did not reduce the time to liberation of oxygen, which may be related to a catch-up phenomenon. Another explanation may be that people that don't die, they are in need of more oxygen. So this could also be related to the survival benefit there. So imatinib reduced mortality as well as time on the ventilator. And I guess we can't say at this time that imatinib should be given to all patients. But the good news is that a novel trial has started in the Netherlands with exclusively on critically ill patients in need of mechanical ventilation, and the primary outcome will be extravascular lung water. So it will be a physiological study. We'll insert PICO catheters in all patients and measure the delta extravascular lung water. And with this, I would like to end. Thank you for your attention.
I'd like to thank the speaker for the talk. Anytime somebody mentions tight junctions, it warms my heart, so thank you. The next speaker needs no introduction because he's already been introduced once, but you know you're unbelievably awesome if you get to give 2 talks in the same session. So Dr. Anand is going to speak to us again about anti-complement factors for all. You know you're awesome. 2 talks in 1.
Thanks, Craig. Good afternoon again. So let's talk about the complement activation and potentially target for COVID patients. So here are my conflict of interest. So basically, a terminal complement pathway contribute to organ failures and death from sepsis more broadly and more specifically from SARS-CoV-2 infections. So there are available a number of molecules that modulate the complement pathway, and so there might be opportunity to use these treatments to help saving life from COVID-19. So I will skip this background because now everyone is almost convinced. Also, there is no definite proof that COVID-19 and sepsis are equivalent disease. At least they share many aspects in terms of pathophysiology. So as you know, the complement is activated by main 4 pathways. The classical pathway basically results from direct interaction between C1q and the surface of pathogens. The lectin pathway involved the mannose binding that connect to carbohydrate molecules on the surface of pathogens. There's also the alternative pathways where the spontaneously activated 3B fragment will interact with the surface of the pathogens, and finally the coagulation pathway and thrombin can directly activate complement factors. So basically downstream you got the anaphylatoxin C3A and C5A, which play a major role in the control of and the regulation of inflammation, and of course at the very end the membrane attack complex that helps killing the pathogens. So C5A anaphylatoxin has pleiotropic effects in controlling the inflammation. They target macrophages and reduce the release of cytokines by these cells. They impair the functions of P and N cells. They upregulate the expression of tissue factor on surface of endothelial cells, promoting coagulation. They induce apoptosis of lymphocytes and adrenal cells. They increase intracellular calcium in cardiomyocytes, impairing the contractility and relaxation of the cardiomyocytes. So there are a number of studies, autopsy studies in patients with COVID-19, showing exactly what is shown on that slide. So basically, from A to D here, you have CD4D deposition in the alveolar septa, and with DAB staining, and this is a nuanced technique in which the C4D fragment appears in green. In this here, you see in red the SARS-CoV-2 virus, and in D here you have a colocalization of C4D deposits and SARS-CoV-2 virus in the alveolar, and the same for the membrane attack complex here, shown here, and in red dots you can hopefully see here the SARS-CoV virus, and here in H the colocalization of the membrane attack complex and SARS-CoV. So there is evidence that in COVID-19, activation of the complement is playing a role in lung disease, but not only in lung disease. One can see that looking at circulating molecules, there is an increase in C5A in concentrations in plasma, and that parallels the severity of the disease. There is an overexpression of the C5A receptors on myeloid cells, with the subsequent promotion of inflammation. So basically, one assumption is that the complement activation might be a key factor in the transition from a non-severe COVID disease to a severe COVID disease. So by intervening and modulating the complement activation, one may assume preventing the progression to severe disease and eventually to death. So during the first wave, we used eculizumab, which is a monoclonal antibody against C5 fragment of a recombinant, as an emergency treatment for adults hospitalized in our units for severe COVID-19. So in this proof of concept study, we evaluate the benefits and risk of blocking C5 by eculizumab in these patients with severe COVID-19. So this was a non-randomized control trial that started on March 10, 2020 and ended up in May 5. And so the treatment was giving according to availability at our site. So all consecutive patients were receiving eculizumab up to the drugs run out, and then they were in the control group, and when we get the drug again, all new consecutive patients were receiving the treatment. So the primary outcome was survival to study day 15, and secondary outcomes were mortality at all the time points, mechanical ventilation and ICU 3 days, improvement in oxygen status by day 15, and also we looked at lactate clearance and circulatory inflammatory mediators. I would like to remind you that in March 10, 2020, many people were dying in our ICU from COVID-19, and that there was absolutely no treatment by this time. So this is why we were looking at this ambitious primary outcome, because no drug was available by this time, and many of these very sick patients were dying, and dying quickly, with the pressure to free ICU beds to admit other patients. So this is why the time point of day 15 was selected for this study. So here are the baseline characteristics. There's nothing to say about it. And this is some data illustrating levels of CH50 assay, CH50 assay as a good indicator of activation of the complement pathway, showing that there is huge activation in complement in these patients that was sustained over time up to day 7. And one can see that the monoclonal antibody eculizumab was able to dramatically attenuate the activation of the complement in these patients. But one also can see that the duration of treatment was transient in about half of patients, and this definitely was linked to the short half-time, to the surprisingly short half-time of eculizumab, suggesting that the drug was highly consumed to interact with C5 that was in excess in the blood of these patients. So looking at time course of anaphylatoxin C3A and C5A and the membrane complex attack, one can see that the concentrations in the blood of the patients remain high sustainably over time, suggesting that the activation of the complement pathway is really a process that is sustained over time in these sick COVID-19 patients. So the main outcome was very, let's say, encouraging, because in this non-randomized trial, we found a remarkable reduction in the death rate at day 15, and also patients who were in the control group were dying more rapidly than the treated patients. And this also came with a favorable effect in lung function, as witnessed by the improvement in the pH ratio and the number of patients who were shifted outside the dangerous situation of having a pH ratio of less than 100 millimeters, of less than 100. So there were also favorable effects of the treatment on the coagulation parameters, increase in platelet counts, increase in the proton-to time ratio, and also improvement in liver function. With regard to the lactate levels, the clearance of lactate was accelerated by the treatment, and there was a slight but non-significant effect in the levels of circulating pro-inflammatory mediators. So that comes with a price to pay, which was an increase in the risk of superinfection and of bacterial infection in the treated patients. There are a few ongoing RCTs using different molecules to block the complement pathway. This one from Niels Riedelman is really interesting. Now they are moving to a phase 3 phase with this monoclonal antibody that specifically block C5a, so that prevent the decrease of the membrane complex attack and may help reducing the risk of superinfection. So very rapidly, they found no effect in the phase 2 trial of the pH ratio or on glomerular function rate. However, looking at the kidney, one can see this is the experimental arm, this is a control arm over time, and in green, this is the patients with normal kidney function. So one can see that indeed the treated patients were more likely to recover normal function than the others. So to conclude, patients treated with eculizumab improved survival, accelerated LATA clearance, improve in platelet counts, reductions in pro-inflammatory cytokines. And so there are potential safety issues regarding the increased risk of superinfection, and we're awaiting for a few randomized controlled trials that are testing different molecules to modulate the complement pathway. Thank you very much.
Thank you so much, Dr. Anane. And for me, as a former smoker, it's a surprise to see the next talk will be by Alain Copes, discussing whether we all need nicotine. Alain from Paris, the floor is yours.
Thank you so much for the introduction. This is first my disclosure slide. I should add to that slide that part of the study I conducted was funded by Pierre Fabre with making nicotine patches. So first we have to go back 20 months ago when the first reports of COVID-19 patients came into the literature. And the first epidemiologic data was striking because there were less smokers in COVID patients than expected from the general population. Here you have data from China, Italy, the US, Brazil, France. The rate of active smokers being from 10 up to 25% as an example in France and China. And when looking at the first epidemiologic data from COVID patients, there was actually much less smokers than expected, a rate between 1 and 5%. And it was just the same for patients hospitalized in ICUs. Here data from China, USA, and France. The first data from last year also showing very low rates of smokers, and we confirmed that initially in a large series of patients diagnosed in our hospital in La Pitié-Salpêtrière in Paris, France, patients with symptomatic COVID-19 positive PCR. There was 201 in-hospital patients and 139 outpatients. And when looking at the subhazard ratio for mortality, whether it was inpatients, outpatients looking only at healthcare workers or without them, the hazard ratio was always in favor of protection by smoking and a reduction of almost 75% of the occurrence of the disease. Still, when looking at more recent data, this is a systematic review and meta-analysis of the outcome of severe smoker, heavy smokers, once hospitalized, developing the disease and hospitalized in the ICU, they clearly develop a more severe disease, and in that meta-analysis there was also a trend towards higher mortality. So how's that? Is it rational to explain these first observations? So there are data suggesting that nicotine might downregulate the expression of ACE2 which is, as you know, the principal receptor for SARS-CoV-2 entry in human cells. There's a convincing and a lot of data suggesting this downregulation of the ACE2 pathway when on the other way around there is an increase in ACE and also towards more AT1, angiotensin 1 stimulation, which may be responsible for the vascular, part of the vascular effect of the disease. They also have been suggested that the virus itself may interact with the nicotinic cholinergic system. The virus may enter cells through the alpha-7 nicotinic acetylcholine receptors. This may actually increase the inflammatory response. There is some basic science data about that. It may also be responsible for ageusia and anosmia, which is seen in these COVID-19 patients. These receptors are highly expressed in neurons. This is one paper which was written by some physician in our institution. And once again, there is a rationale to block this pathway and to decrease viral entry in cells with nicotine, which is an agonist of this acetylcholine receptor. And once again, this may decrease also the transsynaptic spread of the virus by also blocking these pathways. So I talked to you about a potential anti-inflammatory pathway and effect also by a specific action of this pathway on the potential to decrease the release of pro-inflammatory cytokine through the activation of this receptor alpha-7 subunit. And those are data here on human macrophages where the vagal nerve stimulation is able to decrease the synthesis of TNF. Similar data here also on human macrophages in culture where acetylcholine is able to decrease the release of here is TNF as well. And when looking at the effect of nicotine, it was even more potent at decreasing TNF in these cells. And since the macrophage is probably one of the key element and actor of the pathophysiologic pathway of the disease in the lungs, there may be a rationale for using also this pathway as a target for decreasing the severity of the disease. Last, there's been also data suggesting that this nicotinic pathway with the acetylcholine receptors may have anti-thrombotic properties. Acetylcholine has been shown to inhibit platelet activations, and the specific alpha-7 subunit receptor deficiency is associated with higher inflammation and platelet activation. So there is a rationale also for an antithrombotic property of these drugs. So this is here summarized what might be the rationale for using these nicotinic drugs and pathways in patients with COVID-19. So this was a rationale for setting up the Nicovidria trial, which evaluated the efficacy of nicotine patches in COVID-19 patients in the ICU. We enrolled 220 patients. This was a double-blind randomized study. The stats made the hypothesis of 15 points reduction in day 28 mortality from 35 down to 20 with 80% power and alpha at 5%, leading to 110 patients per group. We included patients with the age over 18 who had a confirmed diagnosis of COVID-19, who were hospitalized in the ICU and intubated and mechanically ventilated for less than 48 hours. And the patients had to be non-smokers, non-vaping or abstinent for at least 12 months. They were randomized to receive either nicotine patches or placebo patches. The treatment with nicotine was 14 milligrams per day during the time of mechanical ventilation and up to 2 days after successful extubation, or a maximum of 30 days. And then there was a tapering period of 3 weeks following the treatment. Once again, the primary endpoint was mortality at day 28. And I'm very unfortunate because we are still in the process of analyzing all the queries. The study should have been completed in the middle of August, but we are still lacking some data, so I do not have, I'm very sorry, but I do not have the results. The database will be locked in the coming days, and the results are expected maybe sometime later on this month. This is my last slide, but this is a very important message here. Smoking kills, and you should not go start smoking, and if you are smoking, please quit smoking. Thank you so much.
So we don't have time for questions. We can take questions afterwards. I will say the sign of a truly successful talk, number one, is when the chair of the entire meeting is sitting in the front row taking pictures of your talk. So Dr. Vincent, taking pictures, great talk. And secondly, leaving us all hanging, waiting to come back to the meeting in March to find out what the results are. So great talk. Our next speaker is Dr. Annoni Filippo. I apologize if I pronounced that incorrectly, who will be speaking to us on manipulation of the renin-angiotensin system.
So thank you very much. I have no conflict of interest related to this presentation. So our knowledge about renin-angiotensin system has dramatically improved over the last decade. Let's say we have moved from a linear, slightly simple cascade of biochemical reaction that leads to a couple of effectors, including aldosterone, that tightly regulate water and salt homeostasis in the body, to something that looks a little bit more like this. This complex yet schematic representation of the RAS in the brain serves just the purpose to show you how many compounds, effectors, enzymes have been characterized, studied, developed in the past few years. Nowadays, probably we should talk about the system as a complex network of reactions that are tightly up-regulated and down-regulated by multiple feedback mechanisms that are involved in the controls of several physiological processes around the human bodies. And this thorough crosstalk between a systemic RAS in the bloodstream and more specific, like organ-specific or even tissue or cellular-specific set of these systems. And this is particularly important when we relate RAS to coronaviruses. As you all know, it has been found the first SARS outbreak, how the Ace Ii was serving as a functional receptor for the virus. So it came only natural to look back when the pandemic hit, again, Ace II has been found to be the functional receptor of the virus. And explosions of theories have been published, the most popular being the one we have just heard, that stated that due to the internalization of the membrane-bound pneumocytes ACE2, we probably would have seen an imbalance in the renin-angiotensin system towards a pro-fibrotic, pro-inflammatory, pro-thrombotic classical pathway mediated by angiotensin II, in the downregulation of the so-called alternative renin-angiotensin system, mediated by angiotensin 1-7 and the MAS receptor. Unfortunately, when we and others have measured with highly sensible techniques such as mass pact those compounds, we have seen that angiotensin 1-7, compared to healthy individuals, was also upregulated. And when we pool all the data together, including less reliable techniques such as ELISAs, we can see that both axes seem to be overregulated. If this is a phenomenon of relative insufficiency rather than if it's happening in every kind of patients, all ages, all phases of the disease, all severities, is yet to be determined. To be complete, someone has also postulated that it might be the feedback mechanism, so the enzymes that actually produces the symptoms of the disease. But I will not talk about this interesting hypothesis because no clinical trials are nowadays investigating this hypothesis, very recent. For the sake of simplicity, we can regroup RAS manipulation into three groups. A group of study that seeks to block the so-called classical RAS, a group of study that seeks to boost the so-called alternative RAS, and also a third group in which effectors of the system have been manipulated but not proposed as specific COVID-19 therapies. Since over 1 billion people are currently taking a daily dose of ACE inhibitors or statins, first question was, should we stop or should we continue those medications? And this meta-analysis, you see 52 studies, only one RCT, but over 100,000 patients from all over the world were included. And it seems that no risk was associated with discontinuing those drugs, even maybe a protective effect in hypertensive patients. Since then, 3 randomized controlled trials have been published. The largest, the Brace Corona, is a registry-based neutral study carried on in Brazil. The second one, the Replace COVID, used an interesting system of a global rank to estimate a whole, let's say, bunch of interesting clinical outcomes, and it was also neutral. And the third one, the SI COVID, it was a neutral study, but interesting, involved more severe patients, more hypertensive patients, and despite being neutral, if we would have applied the same global rank used in the Replace trial, actually suggested for discontinuation in more severe patients. But nowadays, the evidence tells us that we should probably not stop this medication unless some clear indications such as hypotension or vasoplagic shock. Whether we should start de novo those medication has intensively been researched. I think it's particularly interesting, the bottom study, that you can see proposed to deliver a medication directly to the RAS, but not to the systemic RAS, to the RAS in the lungs. But the question is yet to be answered. In the group 2, the first one that I want to discuss is the recombinant Ace Ii. So far, only one case report has been published. Seems that in that patients, angiotensin II went down, angiotensin 1-7 went up, and the viral load went down, despite the viral load was already going down before the medication. The study has been carried out, 180 patients have been enrolled, but so far the results comes only from clinical trials, and it has not been published to my knowledge. It seems that the secondary outcomes are still reported significant, an increase in ventilatory free days, reduction in viral load, and the expected modification in RAS metabolites. A secondary study that I would like to discuss is this one. Compound 21 is a non-peptide AT2 receptor agonist. Again, here 100 patients have been included. The secondary post-hoc analysis seems to favor treatments, but since January, we have just access to those results, but no publication has been made available. Yet a bigger study has been programmed, as you can see at the bottom of the screen, called ATTRACT-3. A whole bunch of studies have been proposed using angiotensin 1-7 or MAS receptor agonists, such as the Bio-101, but I have to disclose only that I can talk about those 2 studies where I participated as a co-primary investigator, and the only thing I can say is that phase 1 has been terminated, phase 2 has been closed 2 days ago, and we will have results soon. The other study that is reported completed used the doses that are way higher than the one we used, did not include patients in intensive care, and there are no results made available so far. A third group of studies can be studies in which angiotensin II was given as a vasopressor. This approach has been tested in a series of patients with vasodilatory shock and deemed to be safe. This approach has been criticized based on the theories we have just presented, but it has to be disclosed that it wasn't presented as a therapy for COVID-19, but yet a therapy for vasopelagic shock resistant to other vasopressors. That's probably the reasons why another larger trial is now ongoing to test the safety of this drug. Coming to conclusions, I think that renin-angiotensin systems plays a crucial role in the interaction between SARS-CoV-2 and humans, but despite consistent efforts, we're still missing its role, and RAS manipulation still offers a promising therapeutic strategy in COVID-19 patients, but we still have to advance in a better physiology and physiopathology behind those manipulations. And with this, I would like to thank you for your attention.
Before my colleague introduces our next speaker, I want to personally apologize to you, since I believe I got your first name and your last name backwards, and so I do apologize.
Next speaker from Modena is Dr. Girardis, talking about immune response to therapy.
Mr. Chairman, thanks a lot for the invitation. My presentation will be just a little bit different than the previous one, because I try to make some personal reflection, I think daily life reflection on the use of these drugs in patients with COVID-19. First of all, I want to declare that I'm in favor of randomized controlled trial. This is the only way for better understanding which is the right treatment for the right patient. I just believe that we can do better, because many of the treatment, I have no conflict of interest for this lecture, because I think that many of the treatments that we apply in our patients are based on two simple criteria for applying. And I will try to show you that one of the most important things that we have to measure in this patient, to have to assess, is the immune response. That, in my view, I think also for Peter, after me, is the key for better treatment of this patient. I tried to put in this cloud of words the indication on the words using the guidelines for when and in which patient we have to use, for example, antiviral, anti-inflammatory therapy. It's just very confusing. And in fact, when we look to the most used criteria for randomized controlled trial, I know it's quite important during pandemics to be very pragmatic, but the most used criteria for inclusion in the randomized controlled trial or subgroup analysis and then in evidence-based guideline are risk factor of the patient. Here I just mentioned age, BMI, and so on. The time from the occurrence of infection or signs of infection or the first positive swab, the severity based on which is your PO2, FU2 level, which is your oxygen needing, are you ventilated or not ventilated, and the last one, the location. If you're at home, in hospital, normal ward intensive care unit. In the right part of the slide, you have the last published, I think, 2 days ago, indication from the NIH for treatments. And in the yellow, orange, two colors of orange, I know in English, and the red one, you have why you have to use this kind of treatment. Yes, this is based on the clinical trial, but this is not the way, I think, for still improve our treatment on this patient. So, we are looking for many years in sepsis and now in COVID-19 for a personalized application of treatments. I think this is not the right way. In fact, I think that in this room, many of us are just in the bottom of the slide, but I'm sure that risk factor times severity of the disease, location, I don't believe is related to the viral load, or is not related or just in part to the inflammatory response of the patient. I just treated more than 1,000 patients with COVID-19 before and during the ICU. In ICU, and of course, the heterogeneity of the patient at the hospital arrival, in the transition between normal ward to intensive care unit, during the intensive care unit stay is completely different in terms of inflammatory and immune response. And I think that we have to be, in some way, more precise in evaluating the immune response of this patient for deciding which is the right therapy, and particularly when we talk about cytokine blocking agents, anti-JAK, and steroids, and whatever you want, but we should be more precise because this is part of our activity in genetic and immune response in sepsis in our hospital, very dedicated to this point. We understand that at the end of the story, Covid19 is quite a viral sepsis. And we know from bacterial sepsis, plus fungal sepsis, that the immune response may vary significantly between patients, among the patients. My suggestion is for application, the right application of a treatment, particularly devoted to antiviral treatment as well as to anti-inflammatory treatment, we have to focus on the response. I tried to put some idea coming from the literature presented before on steroids. It's completely different if we have patients with or without hyperinflammation or immune paralysis, or with high viral load or without viral load in terms of effects of steroids in facilitating or decreasing the viral load of the patient. Of course, this is coming from data of trial, some pathophysiological ideas, and also from some pharmacological properties of the steroids. Of course, we have just to discuss about the dosage and so on. The same is for cytokine blocking agents, sarilumab, tocilizumab, anakinra, and so on. We use it since the first hour in our patient, not really in the ICU, but before. We had the first trial in Italy, 2 trials in Italy on the patient before ICU admission were negative. But of course, the problem is which is the right window in terms of inflammatory and immune response. I don't think that oxygen needing is the right parameter, the right criteria for deciding if a patient must or not receive tocilizumab. Why? First of all, as Anthony Gordon said before, we can have some safety reason for avoiding that, particularly cytokine blocking agent and steroids. But as shown before by meta-analysis, by data coming from randomized control trial, we have absolutely no indication of increase of adverse events. That's right, but I just some observation. The first one is the population in the trial, the patients in the trial were completely different. And the risk for infection in a patient in a normal ward to a patient in the ICU is different. Second point is the same for steroids and cytokine. But if we look to the randomized control trial included in the meta-analysis, very few trials really seek for viral and fungal infection. So my concern is today, for sure, in a patient with mechanically ventilated tocilizumab plus steroid may be beneficial, but it depends on the patient and the time of application. And if the patient is at high risk for fungal or viral reactivation. And in fact, this is just my final slide, pre-final slide. We had 2 patients admitted in our ICU because we are a COVID-19 ICU in my region, devoted to the treatment of patients with liver dysfunction, because we have also an acute liver dysfunction program in our hospital. We received 2 patients coming from my region with acute liver failure due to reactivation of herpes viridia after tocilizumab and steroid administration during the first wave of the COVID-19, the first Italian wave of COVID-19. In my conclusion, my take-home pictures are the 3, if you don't measure, and it's important, particularly in the trial, and more, as you understand, I'm in favor of randomized control trial, but it's quite difficult in a trial with also using subpopulation analysis, it's quite difficult to have a clear picture of the immune response of the patient, and the immune response of the patient could be completely different when we treat the patient in our ICU. Thank you so much.
Thank you for a very provocative talk. It's a little bit confusing to me because this morning Professor Vincent said very clearly, all patients are exactly the same. That's exactly verbatim what you said. Perhaps you were not being serious though, in which case it leads directly into our next speaker, Dr. Peter Pickers, who's going to talk to us about suppress or boost the immune system. It depends.
Thank you very much, Mr. Chairman. And I think this afternoon we learned a tremendous lot about new drugs and some amazing results and some disappointing, but I think the general feeling is how can we select patients that are most likely to benefit? And so most of these drugs are suppressing the immune system, but maybe we should not give it to a specific patient, or maybe there are even patients in which we should do the exact opposite. So that's the talk I'm going to present. So we learned a lot about the virus itself, the importance of the spike protein and how it connects to the cells, and that the ACE receptor is relevant for the virus to enter the cells. And we also learned a lot about the host response. And the initial thought was that there is a cytokine storm. And actually, when we started measuring the systemic inflammatory response, indeed we found, it's been mentioned before, that in COVID-19 patients, the cytokine levels are actually lower compared to bacterial sepsis patients with ARDS, and most of the times also in sepsis patients without ARDS, and that the cytokine levels are much more comparable to patients in the ICU that had a cardiac arrest or were multiple trauma patients. So there is no systemic cytokine storm in critically ill COVID-19 patients. Now, does this mean that hyperinflammation is not of relevance in these patients? I think not, and for three reasons. Let me show you. One reason is that in those patients that are most severely ill and eventually die, these patients, a small study in 15 patients that died, it was found that in their bone marrow there is actually hemophagocytes, and this is a sign of macrophage activation syndrome. Also the high ferritin levels that we measure in these patients, and so this is a signal that there is indeed high cytokine production in some of these patients. These are two very nice studies that also compared cytokine levels in endotracheal aspirate compared to the circulating levels. And what they found, as you can see in this graph, is that in the lungs, cytokine levels are actually 10 to 10,000 times higher than what we measure in the blood. So there might not be a cytokine storm systemically, but there is at least a storm in the lungs. And the third reason to think that hyperinflammation is of relevance in most of these patients is that the pharmacological therapies that have been proven to be effective were mostly suppressing the inflammatory response. So they are focusing on the very late phase, the hyperinflammation in most of these patients. Now, we've known this trial clearly, the trial that changed the treatment of the COVID-19 patients, a very large trial, and it was found that indeed, overall, dexamethasone was able to improve survival in all patients, and then also the patients that benefited most were those that were treated with mechanical ventilation, also a benefit if there was oxygen only, but the curves flipped actually in those patients that did not receive oxygen, so there's also a signal of harm in less severe patients. This is a very nice follow-up study because it's a smaller study, 428 patients, of which 280 received dexamethasone, and they actually tried to find a specific subgroup of patients that were hyperinflamed. And what they did was they looked for elevated cytokines and higher SOFA scores, and in the total group, they did see a hazard ratio of 0.8, so there's a signal of benefit, but this did not reach significance because of a little statistical power. But in the subgroup of hyperinflamed patients, that was even smaller, the reduction in mortality was even much more pronounced. So that shows, indeed, that apart from needing oxygen, yes or no, or mechanical ventilation, so more related to disease severity, that also, if you look for hyperinflammation to enrich your patient group, that there might be a more benefit, a subgroup that benefits more from this treatment. So one size does not fit all, I think, and we should look for that. The same appears to be true for tocilizumab. So we know, as mentioned before, that overall there was a benefit for critically ill patients. And again, there was a small follow-up study, 146 patients. And in this study, prior to the administration of the antibody, they measured the IL-6 levels in these patients, and they found, one, that the higher the IL-6 level, the more likely the patient was in need of mechanical ventilation, but there was also a relationship to the therapeutic efficacy of the antibody. So you can see this here, that the very top line of this Kaplan-Meier curve shows those patients with low IL-6 levels that did not receive tocilizumab. They have the best prognosis. The very bottom line is those patients with high levels of IL-6 that did also not receive tocilizumab, so these patients have the worst prognosis, 4.6 times more likely to die. However, in patients that have high IL-6 levels and did receive tocilizumab, that curve goes back to the low level, so there's a benefit of tocilizumab in that group. But most importantly, I think, that in those patients with low IL-6 levels that received tocilizumab, there was actually a significant signal of harm. These patients were also more likely to die, and so even though there's no clear signal that there are more secondary infections or whatever, but anyway, if your IL-6 is not elevated and you give an antibody, this might not benefit or even harm the patient. So immune suppression is mainly beneficial in hyperinflamed patients, I would think, but not all patients are hyperinflamed. That is the main message. We measured HLA-DR expression in our institute because we were interested in immunoparalysis, and we thought that if there's such a cytokine storm at that moment, then it's also likely that these patients become very much suppressed in their immune system. And what we found was that there is some reduction in HLA-DR expression compared to normals, but it's much less pronounced compared to patients in bacterial septic shock. And also over time, it remains the same, as you can see on the right side of this slide. So there is some immune suppression, but it's not very pronounced. And this was during the first wave when the patients did not receive any immune modulating drugs. So it can be more pronounced now if we treat them with steroids or anti-IL-6 antibodies. Now, the next question is, could it be of benefit to a subgroup of patients to boost the immune system if they suffer from a suppressed immunity and, for example, have ongoing persistent shedding of the SARS-CoV-2 virus, or if they have opportunistic infections? So there's no literature on it at all, but we have some case reports, and I will tell you this. So we have treated several patients that are renal transplant patients that had COVID-19. And what we found in these patients that they kept on shedding the virus, and we also did viral culture. So it's a live virus for 50 to 60 days in the ICU. They were not able to clear the virus because these patients were, of course, on immune suppression for a long time. And so in these patients that were not improving, we thought about treating them with interferon gamma. And we did, and what we found indeed, as you can see in these boxes, that during the treatment with interferon gamma to boost the immune system, the virus indeed became negative, the cultures became negative, so they were able to clear the virus, and at the same time we had no negative effects concerning, for example, their transplant kidney. So there can be a benefit maybe for these patients. I don't know if they lived a happier or longer life, but at least they got rid of the virus. And another patient that was not pre-existently immune suppressed, but had a very complicated course is this one. He came in with a CRP of 54, so not that high. Nevertheless, he was treated with oxygen and went to the ICU, so he received both dexamethasone and tocilizumab. However, 1 week later, he started to accrue all kinds of opportunistic pathogens. These were treated with the appropriate drugs, but they did not clear these infections, and he did not get better. He got worse, actually. So then the decision was made to measure his HLA-DR. It was only moderately suppressed, but there was some immune suppression, and he was treated with interferon gamma. And following that, the opportunistic infections disappeared, and this patient could be weaned and left the hospital alive. And as you can see, the treatment also is related to an increase of HLA-DR levels. So I think there's clearly no randomized controlled trial or even large case series, but we have to think, as the previous speaker also said, about where are we in the immune system, and it's likely that some patients might benefit. So my main key points are that there is no systemic cytokine storm, but there is a local storm in the lungs. Clearly, there is evidence of inflammation-induced injury to the organs. Overall, anti-inflammatory therapies show benefit, but this is more pronounced in hyperinflamed patients, and so immune suppression is mild by COVID-19 itself. It may be more pronounced now by the therapies that we give, and so there are some patients that might indeed benefit from immune suppression, but there are also a subgroup of patients, and it's likely to be a much smaller subgroup, that might benefit from immune stimulation, and so we should look into that, and of course look at the clinical outcome effects to see if this is right. So I think, as in sepsis in general, we are moving towards a much more personalized approach, and I think we should do this also for COVID-19 patients. Thank you very much.
Thank you, Dr. Pickers, for sharing these exciting perspectives. And now we go to the recommendations of the World Health Organization by Bram Rochberg from Hamilton, Canada.
Good afternoon, everyone. Bram Rochberg from Hamilton, Ontario, Canada. My pleasure to be speaking as part of this session. Appreciate the invitation. What an amazing marathon of COVID presentations we've had this afternoon. I will be presenting on the WHO recommendations. In terms of declarations, I do treat patients with critical illness from COVID. I was fortunate enough to act as methods chair for the WHO guidelines, along with others, including Dr. Francois Lamontagne, who is in the audience here today. I'm a member of the GRADE working group, but have no other academic or financial conflicts of interest. Pretty amazing that even this far into the pandemic now, almost 2 years, we're mostly left with looking at repurposed drugs, the drugs that had been given for other indications that we're now exploring in the role of COVID-19. Most of them either antiviral or immune mediating, at least. And around these different agents, there's been enthusiasm from different sources, and sometimes misplaced enthusiasm, as was the case with hydroxychloroquine and our orange-haired friend from the United States. The challenges early on in the pandemic were the amount of information that was there, and you could imagine putting yourself in the place of a bedside practitioner with rapidly evolving information, new data being published on a daily basis. It's extremely challenging to keep up with the latest literature. And here's where there's a role for clinical practice guidelines, especially ones that are vetted and produced using proper methodology. Clinical practice guideline methodology has evolved a lot over the last 15 or 20 years. And this was a seminal publication by the Institute of Medicine in 2011, which set these standards that we use to produce guidelines. A transparent process linked to a systematic review of the evidence, including many stakeholders as well as patients, and a lot of factors that go into making recommendations, not just the evidence, but also including certainty of the evidence, patients' values and preferences, costs, resources, other considerations as well. The WHO guideline represented a collaboration between a number of groups. One was the Magic App Platform group, of folks that were trained mostly at my home institution of McMaster and already had a platform in place that provided an avenue for rapidly disseminating clinical practice guidelines from evolving evidence base. We partnered with the World Health Organization. Janet Diaz, pictured there, was the lead from the WHO that collaborated and contributed to guideline production. We worked with the BMJ, which was our outlet for the guidelines. Each of the WHO guidelines has been published within the BMJ. And then only what I can describe as a random grouping of Canadian intensivists that were also interested in guideline methodology, of which I include myself and Francois and Srin Murthy, who some of you may know as the third individual. The guideline development was all done under the auspices of the WHO. It was very humbling to be a part of these efforts, truly multinational and collaborating with individuals from literally across the world. We made sure that we had representation from all 6 WHO regions. We had patient partners, survivors of COVID illness that partake in the guideline development. And we followed very strict grade methodology, which included conflict of interest management. And this became very important as some of these new drugs were discussed and the financial implications that went along with recommending for or against them. Central to any guidelines is the evidence base informing the guidelines. And I mentioned already is that any properly done guideline requires a systematic review and meta-analysis if possible to inform the recommendations. We were fortunate here to work with a group also based at McMaster that was performing a living network meta-analysis. And for those that aren't familiar with network meta-analysis, this is an analytic technique that allows you to include all different interventions used for a specific illness, all within the same model. And you're able to combine both direct and indirect evidence. This is what's called a network map from our most recent network meta-analysis. And you can see all the different drugs that have been investigated and included as part of the analysis. Okay, enough of the background. What were the recommendations that have been made to date? We've addressed 6 drugs to date. There's a 7th that will be recently published in the next little bit, looking at the monoclonal antibodies. But these are the agents that we've addressed so far, which we'll go through in turn. Given the landmark publications in September of 2020, you'll probably not be surprised to hear that we made a strong recommendation for corticosteroids in patients with severe or critical COVID-19. This was one of the recommendations that was led by Francois, and certainly seemed like the benefits of corticosteroid in the setting of COVID-19, again, those that are hospitalized or requiring oxygen therapy far outweighed the harms. I'll be honest, I'm no Nostradamus, but I sort of thought this might be the case and had been using corticosteroids in my COVID-19 patients, especially those with ARDS, even prior to these landmark recovery trials. And mostly because it's a fairly consistent effect, actually, when you look at corticosteroids in non-COVID ARDS versus COVID ARDS. This from a systematic review led by a research fellow of mine, recently published in Intensive Care Medicine, and compared the effect of corticosteroids, any agent, in ARDS from COVID versus ARDS from other etiologies. And you can see that, again, the point estimates are fairly consistent. It seems ARDS is an inflammatory-driven process, regardless of the cause, the underlying etiology, and again, there's benefits with immune suppression with corticosteroids in both situations. Remdesivir is an agent that received both positive attention but also controversy over the last year and a half. And I think Craig already alluded to the variation in practice that we see with remdesivir even to date. As part of the WHO, we made a conditional or weak recommendation against remdesivir. The panel concluded that not that there was no benefit, but that the evidence that was currently available did not support improvement in patient-important outcomes. A lot of the variability that you see with use of remdesivir really comes down to the subgroup effect and whether you believe it or not. You can see that in those that with critical illness from COVID, it's quite clear that there's no benefit from remdesivir. However, in the severe subgroup, those that are hospitalized but not requiring intensive care, perhaps benefit. At least for our panel, when looking at the evidence, we had low certainty in the overall effect. And then when you start taking low certainty evidence and now starting to carve it up into individual subgroups, you can see that the overall numbers here when it comes to mortality are very small. And the WHO panel decided that their credibility in this subgroup finding was low and not high enough to support subgroup recommendations specifically aimed at the hospitalized. Lopinavir, ritonavir, hydroxychloroquine both made strong recommendations against, despite the early enthusiasm, again, by certain political figures. Once large-scale RCTs were done investigating these agents, it became quite clear that there was no benefit and actually harm from a cardiotoxicity as well as a GI upset perspective. Ivermectin, I'll perseverate on for a moment. This has probably been one of the more controversial recommendations that we made as part of the effort. Perhaps not controversial amongst those that are in tune with the science, but you may be aware that ivermectin has a very strong social media following associated with it. It tends to correlate with also those that are anti-vaccination. We made a strong recommendation against ivermectin, although with the caveat that we feel like well-done randomized controlled trials must continue evaluating this agent. Since our publication, since this recommendation, one of the largest trials showing benefit has actually been retracted because of concerns around fraudulent data. I'm on Twitter myself, some of you may be, and I find the hate that I received after, or that we received after publishing this was quite monumental on social media. To the point that, you know, I can post now about it being a rainy day and somebody will reply, if you prescribed ivermectin, it would be sunny. I've been called contributing to genocide and all this sort of thing. It's quite alarming, actually. But certainly when you look at the data that's there, until further randomized controlled trials are completed, there is not data to support the widespread use of ivermectin. The last agent, I realize I just have a moment more. The last agent that we've made recommendations on were IL-6 inhibitors. Probably if there is an optimal window for IL-6 inhibitors, it's right at that point of clinical deterioration. Upon looking at the evidence summaries, the guideline panel made a strong recommendation for IL-6 receptor blockers, both for severe and critical illness from COVID. And given this consistent effect that we had heard about already today between tocilizumab and sarilumab, this strong recommendation applied to both agents. Pretty unbelievable what we've accomplished in such a short period of time. These platform trials have been a large contributor to this, and certainly excited about what's to come from these platform trials as well as other research when you think where we were 18 months ago and the hopefulness in terms of where we might be 18 months from now. If you're further interested in our guidelines, there's a couple of links to access them through the BMJ, WHO, or MAGIC app, and I will leave you with this emoticon-driven summary graphic by a colleague of mine, Dr. Kadir at UCLA, that summarizes our thoughts around some of these agents. Thank you very much.
Thank you. I would encourage everybody to tweet at him right now, but nice things. Our final talk for the day, and again, I want to thank everybody who stayed. This has been a marathon session. This is speaker number 16 in this session without a break, and you guys made it throughout. This has been a phenomenal session. We're actually not going to take questions afterwards, so speakers stick around. People come on up to discuss because we have so many speakers. I hope the answer to this question is yes. Our final speaker, and again, I apologize if I'm pronouncing your name wrong, is Dirk Lenny, who's going to say, have we made much progress?
Thank you very much. And my last name has been pronounced before as Dirty, so I'm happy with anything but that. Thank you for staying in this long session. I'm very happy I have the honor to end this session with the question, if we have had much progress. And the answer to that is obviously yes. You've seen all the speakers today who've all made an outstanding contribution to the science, to the treatment of patients with COVID-19. But I think a thank you to them should be extended to all people in the room, because you know, whether you've treated clinically patients with COVID-19, whether you've included a patient in a trial or run one of these trials that's been presented today, a big thank you to the whole ICU community for making the progress that we have made. If you want to look at progress, then there are a couple of ways to do that. This is one of them. You just look at the number of cases of COVID-19. This is not a global graph, this is a Dutch graph, and what you can see here is the whole pandemic in the Netherlands. This is the number of cases per 100,000 inhabitants. And what you can see is that in the beginning, obviously, it seems like we didn't have much of a surge, but we did. We just had very limited testing capacity, so that's probably how the graph should look. And what you can see if you look at ICU admissions is that each and every one of these surges, of these waves of the pandemic, was followed by a wave in ICU admissions. So we had a couple of surges and we had a really rough autumn last year, like many countries in Europe. But the most interesting thing is in the right bottom of the slide, because what you can see is in the last surge, that was early this summer because we relaxed measures a bit too enthusiastically, there was a huge increase in the number of cases, but there were relatively few ICU admissions. So that's not an effect of pharmacotherapy for COVID-19 mostly. It's the effect of vaccinations. And I think that's one of the most important pieces of progress that we've made here. So, you know, despite all the progress in this session, vaccinations are what's going to get us out of this pandemic. And it's just amazing that we have more than one superb vaccines and that we had them within 11 months of the start of the pandemic. But that also brings the other side of the medal, which is shown in this picture. And I think here a picture shows you or tells you more than 1,000 words. So this is something we haven't done very well. So there's not enough equitable access to vaccines across the globe. And that's what this picture shows you. So yes, we've made progress, but there's also still some work to do. Going back to pharmacological treatment for COVID-19 and focusing on ICU patients, for evaluating the effectiveness of drug therapies in ICU patients, you need to understand the mechanism. There's been a couple of excellent presentations on that, but the proof of the pudding is in the randomized controlled clinical trials. And also there we've made progress. This is a slide from the last pandemic, or one of the last pandemics. This is data from the influenza pandemic that we had in 2009. What you can see on the y-axis is the number of patients. So that's the number of patients, not the number of trials, that were included in either prospective cohorts, whether or not on therapy, and intervention clinical trials. And what you can see in the second bar is that data of only 153 patients was published that were included in either therapeutic cohorts or intervention trials. None of these trials, there were 2 trials and 1 prospective cohort, were published during that pandemic. So admittedly, that was less disruptive than this one, but it lasted for almost a year. None of those data were published during that pandemic. So we've made amazing progress. There are, you know, hundreds, thousands of trials, and this is data from a WHO source. Other sources give slightly different estimates, but there are thousands of trials being run on COVID-19 across the globe. So that's progress. What you can also see if you look at that same website is that many of these trials were started early, very early in the pandemic, which is a great improvement from the last, or the influenza pandemic. You can see that up to 130 trials were started each week at a certain point. But also here, there's another side of the medal. So of these thousands of trials that have been started, only about half of them is actually recruiting patients. So that's a lot of research waste. And so far, only about just over 200 have been published. So that's a very low percentage. And we've included globally less than 1% or less than 0.2% actually of all the patients with COVID-19. So again, yes, we've made progress, but I think there's still a lot to do, because I think we would learn much faster if we would include, you know, even 5% of the patients globally into clinical trials. Zooming in on the actual compounds that have been investigated for COVID-19, I think if we try to kind of summarize all the talk so far, the three pillars of treatment for COVID-19 patients in the ICU are antivirals, immune modulators, and anticoagulation. We haven't heard a lot about anticoagulation, but everybody who's treated a COVID-19 patient in the ICU knows that thrombosis is a big problem in these patients. And the tricky thing is that some interventions, may belong to 2 pillars or maybe even 3 pillars. So we've talked about antiviral effect of monoclonal antibodies. You could consider those immune modulators. So, and there's a difference between baricitinib and prednisone, but kind of, broadly speaking, this is my pillar model for the treatments of COVID-19. And we can be very brief about the antivirals. You've heard a lot about it. I think the previous speaker elegantly explained the kind of nuances of the view on remdesivir, but in the ICU, the message is very clear. We do not give remdesivir, hydroxychloroquine, or lopinavir ritonavir. And ivermectin, is still under investigation in clinical trials. That's good, but please don't prescribe it to your patient outside a clinical trial. So that's the orange bullet on my slide. Corticosteroids, we've heard about that. I think we were all, very relieved, happy, and maybe a little bit amazed that modulating the immune system in the absence of an antiviral in the sickest patients worked, but it did, and there have been a lot of very convincing publications about that. Remember that it's only for patients who are on oxygen or more, as we like to say it. I think tocilizumab is a very interesting one, and Tony elegantly explained the trials on tocilizumab, because early on in the pandemic, all these trials, and they were admittedly smaller trials, never more than about 250 patients, but there was not a lot of effect from the drug. If you were, an optimist, you could say, in some of the results, there are some differences between the groups, but if you looked at the primary endpoints, there was really no significant differences. So then there was REMAP-CAP, the first study to show a difference, a survival benefit. And you've seen this slide before. It summarizes the primary endpoint of that trial, which is organ support-free days, an ordinal scale in which -1 is assigned to every patient who dies in the hospital. So even if you have 20 days on organ support, we feel you're better off than being dead. So being dead is the worst outcome. And you can see more blue in the intervention groups compared to the control group, meaning both tocilizumab and sarilumab were effective. So how do we merge the data from these older studies with the recent results of REMAP-CAP and the confirmation of those results by the recovery collaborative group? So I see that as making coffee. So if you chew coffee beans, that's not very attractive. I mean, nobody likes to chew on coffee beans. And if there's an exception, you can come talk to me after this presentation. But if you add water, then the magic happens. Then you get coffee, and we all like coffee. At least I like coffee a lot, so that's why I have a picture of coffee. It's the same with tocilizumab. If you give it with steroids, it works. If you give it without, it doesn't. So don't forget to treat these patients with corticosteroids. This is a network meta-analysis on the IL-6 receptor antagonist that was already referred to in one of the previous talks. And the message here that you have to remember is it doesn't matter if you give toci or sari, as long as you give an IL-6 receptor antagonist in patients who are eligible for getting it. The updated data of REMAP-CAP, including data on anakinra, are now available as a preprint. And Tony mentioned this very briefly, but in this trial, anakinra was not beneficial for ICU patients. So then the question is, how do we merge that with the results of the Save More trial that were also presented here that showed a benefit? So I think the key thing here is they are different populations. In Save More, you were excluded if you had a PF ratio of below 150, if you were on NIV, or if you were on IMV. So that excludes pretty much most ICU patients. Also, they required, obviously, a SUPAR of higher than 6. If you didn't have that, you were excluded. That's not available in many hospitals, I think, at the bedside, but it's a very, very interesting drug to see more studies on. You've heard about convalescent plasma, doesn't work, may work in immune-compromised patients, and there's some developments in monoclonal antibodies, but I wouldn't say it's for all, and I think that's consistent with the presentation we had previously. A last item that we haven't heard a lot about, we could talk about this for a week, but we won't, anticoagulation. I think I'd advise you to have a look at the RAPID trial results that are available on medRxiv and the two publications on anticoagulation from the combined ATTACK, Active4 and REMAP-CAP investigators that show that there's a breaking point again, there's a balance. So therapeutic anticoagulation is beneficial in non-critically ill patients, but not in critically ill patients. So please don't give it to your patients. So this is the summary of what I've just said. Give corticosteroids and IL-6 receptor antagonists to your patients. Don't give the red bullets and other. There are many, many, many questions to be answered. And that leads me back to my first slide. Yes, we've made a lot of progress, but there's still a lot of work to do. And I hope everybody in the room will contribute to that. Thank you for your attention.
So before I hand it to my co-moderator for the final word, does anybody know what I'm doing tonight? At midnight, which is 6 p.m. back home in the United States for me, I have the United States NIH COVID guidelines, and I cannot wait to tell them about this session, which was like debatably the most exciting session I have literally been at in years. So thank you, Dr. Vincent, for putting this together. 16 extraordinary talks that I will be staying up really late to talk about and bragging about. Fantastic session. Thank you, everybody.
I have not much to add. Only thank you all for staying until the end. Thanks to all contributing to these 16 talks. All exciting and a very exciting wrapping up in the end. Congratulations to Dr. Verde for bringing it all together. Have a nice afternoon.